Okay, we are live now.
Good afternoon and welcome to the Oculoplasty part of Ophthalmology Reboot 2020. We had a glaucoma session yesterday, followed by a pediatric neurophthal and retina. And today morning we had a cornea. Now we have the oculoplastics. This is again a who is who in oculoplasty in India is in this webinar. Starting with Dr. A.K. Grover sir, none other than Dr. A.K. Grover sir will be our course coordinator and chairman. And then we have Dr. Shubhra, Dr. Kasturi, Dr. Ani, Dr. Reena, Dr. Lakshmi Mahesh, Dr. Marian, and of course, Dr. Fairuz, who will be moderating the thing. So over to you, Grover sir.
Thank you, Dr. Gopal. It's wonderful to be a part of this beautiful conference organized by the KSOS. And we are looking forward to another very useful session like the several others that you've held. We have a lineup of very eminent faculty who are going to discuss the ocular aesthetics, the eyelid problems. We're going to discuss some of the orbital problems and inflammatory problems as well. But we will begin with the most beautiful subject of all, the oculofacial aesthetics. And we have none other than Dr. Kasturi, who's a doyen in the field of oculofacial aesthetics, particularly, to speak to us on her subject of blepharoplasty for the facial rejuvenation. Dr. Kasturi, please. May I request everyone, all of the speakers, to kindly stick to the time of 10 minutes precisely so that we can discuss for about a couple of minutes and complete the program in time. Dr. Kasturi.
Yes, sir. Can you see all my slides?
Yes.
Yes.
Madam, you can please make it full screen.
Is it okay now?
Yes, ma'am.
Perfect. Audible and visualized.
Thank you very much, Grover sir, for the kind words and for the kind introduction. At the outset, I would like to thank Dr. Fairuz, who happens to be a very dynamic lady of our Oculoplasty Society, doing phenomenal work in oculoplasty. And a very special thanks to Dr. Gopal Pillai, who is a great researcher and a great clinician and academician, a very dear friend of my husband. So I'll be talking about the eyelid blepharoplasty, the facial rejuvenation. When we talk about the changes in the eyelids and the periorbital region, we know that they have a significant impact on the signs of aging, and this often accounts for major concern for seeking the facial rejuvenation. And when we look to the aged eyelid, we see that there can be some laxity of the skin and the underlying muscles, septum, and the tendons, along with prolapse of the orbital fat and the crow's feet and other periocular wrinkles. So the blepharoplasty has been customarily addressing all these changes around the periorbital region. And this word blepharoplasty has come from the Greek word blepharon, which means eyelids, and the plastikos, which means to mold. So this is a time-tested technique that achieves a very satisfactory cosmetic result and gives a very positive change in the restoration of the aging changes in the periorbital region. When we talk about the indications of the blepharoplasty, we know basically there are two indications. First is a functional, especially situation like dermatochalasis where we have a lateral hooding. And in case of epiblepharon, we have the lash ptosis. And because we have the lash ptosis, it touches the cornea, leading so much of corneal irritation and SPKs. So we need to do a blepharoplasty and revert these eyelashes in order to protect the cornea. And the second important indication is aesthetic, where we, especially in situation having a single lid fold, we need to convert into a double lid fold and give rise to a very beautiful crease, along with it increasing the tarsal plate show and decreasing the brow fat span. So this is a very simple surgery that you can see. The most important is that how much amount of skin and how much amount of muscle you need to excise. So you can do a pinch test, especially basically making the patient sit in the supine, in the upright position and not in the supine position. So once you give the marking, the next important step is to excise the skin. The skin should be excised in layers because underlying the skin we have the orbicularis, And this orbital, especially the preceptals, in situation where they come for the aesthetic indication, we already usually excise it, not the pretarsal, because pretarsal will lead to postoperative leg of Tumors. This is being followed by exposure of the orbital septum. And once you expose the orbital septum, you need to incise the orbital septum, and then you need to take out the fat pads. Basically, when I talk about the fat pads, we all know in the upper layer there are two types of fat pads: the central, which is a reddish in color, and then medial, which is a white in color, because embryogenically they are from two different origins. The nasal comes from the neuroectoderm, and the central, which comes from the mesenchyme. So you need to excise in situation where their lids are very puffy or the lids are very thick. And once you excise the fat, the next most important aesthetic step, especially those who do not have a lid crease, is to give a lid crease formation suture. So this lid crease, these are the two fat pads being excised, and then you give the lid crease formation suture where you pass skin, orbicularies, tarsus, LPS, and back to the skin. So likewise, you need to give approximately 4 to 5 sutures, and this is being followed by the closure. The closure is usually given by a monofilament. I usually use a 7-o-proline. And the end stage of the surgery, where you can see a slight eversion of the eyelashes, as you can see here. And if you look to the other unoperated eye, you can see the eyelashes are straight. So you have to little evert the eyelashes in order to also take care of the lash ptosis. So these are some of the people, like you can see this girl, she comes to me with no crease at all. And what she wants is basically a crease, and the crease should be very dynamic in all the views, both the lateral views and also in the different gaze. This another lady, and this you can see along with the blepharoplasty, some amount of ptosis also being corrected. So today, blepharoplasty is the surgery of choice for facial rejuvenation, but however, it is often performed with many other eyelid surgery for the correction of function anomalies, the most important being a lacrimal gland prolapse, or in case of mild upper lid ptosis. So this is a girl, she comes to me with a bilateral lacrimal gland prolapse, and you can see her in all the different gaze. It is really very prominent. Along with the prolapse of the lacrimal gland, you also can see a blepharochalasis. So CT scan shows a very prominent gland. So you need to combine the lacrimal gland repositioning along with the upper lid blepharoplasty. So the initial steps of surgery are same, but this girl, she has a blepharochalasis. So you need not excise the orbicularies, and she also has a very good lid crease, so I do not need to put the lid crease formation. So you need to cut the orbital septum from the medial and to the lateral end, expose the lacrimal gland, separate the lacrimal gland from the underlying LPS and also from the fat. You need to push and see whether it can be repositioned back to the socket. And then you use, I usually prefer using a 6-O polydate, because I feel that if you use a proline, sometimes it leads to cheese wiring. It just cuts through the periosteum. So the first suture is a matrix suture, which passes through the adjoining structures along the lacrimal gland, and then it needs to pass into periosteum. And after you give the first suture, whatever remaining gland is there, you need to push it back, and then after that, you need to give another 2 sutures on the either side. So this is very commonly, in fact, we come across in our situation. So many times, along with the blepharoplasty, we need to combine a lacrimal repositioning of the lacrimal gland. And I usually think that polydate is a much better suture as compared to the other. Even Vicryl is not the bad option, but sometimes Vicryl leads to some amount of reaction. And then this is followed by excision of the fat that is being remaining. And then what you do, you give a skin closure, and you should not overcorrect because she does not have much amount of ptosis. So you should be very careful in repositioning. You should not excess. And this is at the end of the surgery. And this is how beautiful she looks post-operatively. If we look to the pre and the post, you can see a very good repositioning of the lacrimal gland. And also in the different gaze and the different views, you can see the lacrimal gland does not appear prominent. Sometimes we get situation like this, where if you do a phenylephrine test, they come up to be positive. So these are the situation where, along with the blepharoplasty, you also need to do a MMCR, that is a molar muscle conjunctival retraction. So this is a very nice technique which we do for the elderly patient. and a 4 millimeter excision of the molar conjunctiva corrects 1 millimeter of ptosis. So this lady has approximately 1.5 to 2 millimeter of the ptosis. So I'm combining the MMCR along with the upper lip blepharoplasty. You need to give a subconjunctival incision injection in order to separate the LPS, underlying LPS, from the molars muscle. We do not have to cut the LPS. What the only thing is that we need to excise the molars, and also we need to excise the overlying conjunctiva. So I'm using here a 6O PDS suture because I feel that this is monofilament, this is non-reactive. And then you need to give the different passes below the putterman clamp. And you can have a single pass or you can have a double pass, as you can see here. And then once you finish the passes, you can exteriorize the knot, and then this is being followed by the rest of the steps of the blepharoplasty. But once you excise, you must be doubly sure. What I do once I excise the tissue and I complete the procedure, I always recheck whether I have excised the correct amount of tissue, that is whether I have excised the molars and the conjunctiva, because we don't want to have the LPS in it. And also, and this is the another way of doing an internal plication of the LPS muscle. So this is post-operative. She looks a bit overcorrected, but this is how she looks after a few months following the surgery. And you can see a nice correction of the ptosis that has been there. And it is very dynamically, you can see all the keys in different views and different days. But situations like this are really very hard. When you see a patient with so much of laxity of the skin, with so much of ptosis, you can see all the fat spinning coming out. So these are the situations where I usually take care of the lateral hooding by a W incision at the periphery. And at the same time, the ptosis can be corrected with the LPS plication. This is the levator palpebrae superioris mus aponeurosis. You can see it is little light in color because it is more of aponeurosis. And here, what from my experience, I feel approximately 8 to 10 millimeter of LPS plication corrects approximately 1 millimeter of the ptosis. Some school of thought says it is 8 millimeter. Some consider taking 12 millimeter. But I feel if they have, since they have a reasonably good action, I plicate approximately 10 millimeter. So first, different types of plication sutures, numbers of plication sutures are given, one centrally and definitely two, one lateral and two medial. And once it is done, you are sure that the whole of the LPS has been plicated, the amount that is being required has been plicated, and then you give the skin closure. And this is how you feel the amount of some amount of ptosis gets corrected on, also the other fat prolapse skin laxity gets also corrected. Just 1 minute about the lower lid blepharoplasty, because it's a very big subject and due to the constraint of time, the most common indication is the double convex deformity. But what is this double convex deformity? This is characterized by a prominence of the orbital rim, the lengthening of the surface area, and there's bowing and herniation of the fat. If you look to this young girl out here, see the lid margin is quite small. The lid is much less in vertical height. But as we grow old, because of the sagging of the tissue, because of the development of the negative vector and the tear tract, the whole of the lid lengthens. So in such situation, what we do, we need to excise or we need to relocate the lower lid fat during the procedure. So here the most important structure is the inferior oblique muscle. I go by transconjunctival approach, which lies between the medial and the central fat pad. But here I usually go for relocation of the fat. So what I need to do, I need to release this orbitomalar ligament and transpose this orbital fat down from the orbit up to the soup, or centrally sometimes to the beachhead fat that we can see here. So this is how we relocate the same fat of the patient, so that this also takes care of the negative vector along with the correction of all the bulges and also laxity. But one important step while doing a lower lid blepharoplasty, we should always do some strengthening of the lateral canthus, and otherwise you will have the lid retraction. And yesterday in the webinar, we were discussing widely about it. And this can be done usually by a 5O or a 6O prolene suture. And this is a very simple step. And this is what you can see. This rolling, of which is the laxity, which is usually present, you can see post-operatively it is much better. And this is the same gentleman following the surgery, pre and the post. And also what we usually need to assess, we need to assess whether this length has been decreased decrease following the lower lid blepharoplasty. So these are some of the ladies who had undergone the lower lid blepharoplasty, getting a very good result along with the correction of the negative vector. And this, in my experience, and until today, I have not done any recorrection of the lower lid blepharoplasty. I feel it stays pretty long. I have almost 12 years of experience doing a lower lid blepharoplasty. And sometimes along with it, I do a smash lift and also the orbital lift. Thank you very much for the patient hearing.
Dr. Cooper, you're not audible.
Okay, thank you, Kasturi, for a wonderful presentation with those beautiful videos, which were so clear and made the subject absolutely clear to everyone. And we'll now have Shubhra in. Is she in?
She's not in, Dr. Grover. Maybe we can go with Dr. Marian, who's
or me.
You can go ahead with the.
Okay, so I'll switch over now to reconstructive work, which is the reconstruction or repair of eyelids. I'll start sharing my screen.
The other speakers can mute. It will be really nice. We can hear some background noise. Dr. John?
So I'll try and present a simplified algorithm for management of eyelid defects. Let's first look at why eyelid defects occur and why do we need to repair them. They can sometimes be congenital, but most often they're acquired for one reason or the other. The congenital colobomas is one important reason, where you may have more often an upper lid coloboma, more often a unilateral colobomas, but bilateral colobomas do occur associated with other anomalies and an early exposure keratopathy. Lower lid colobomas are again relatively less common. We may have acquired eyelid defects, which are the commoner defect that we see, and they're most commonly due to surgical resection of eyelid tumors. They may be traumatic as well or iatrogenic. Our objectives in lid reconstruction are to restore back the anatomy so that we get a good function back, which is vital for preservation of vision and for tear drainage. At the same time, it is vital that we provide an excellent aesthetics, as that is important for a person's confidence and his ability to deal with the world. When reconstructing, we need to remember that the eyelid essentially comprises two major laminae, the anterior lamina made up of skin and orbicularis, and the posterior lamina made up of tarsus, conjunctiva, and the levator, etc. So whenever we do a reconstruction, we need to ensure that we create a support, inner lining, and an outer lining. So whenever we do a reconstruction, we need to repair both of these laminae, but it is always preferable to have at least one lamina with intact vascular supply. Only then we can expect the other lamina with maybe a free graft to take up the vascular supply and function and survive. When we plan a reconstruction, we need to look at whether the involved eyelid is upper or lower, what is the depth of the defect, whether it involves the eyelid margin or not, the size of the defect, and the shape of the defect. Very often, we need to convert the defect into a desired shape so that we can do a reconstruction in the fashion that is most suitable. The eyelid defects management can be considered as those where the margin is not involved, those where margin is involved, but the size of the defect is variable, and we look at the possibilities with different sizes. And special attention needs to be paid to those where the canthus is involved, either the lateral or the medial. For the non-marginal defects, the principle is generally to convert defects to an elliptical shape and carry out a direct closure where there is no tension or pulling effect on the margin. In the upper lid, all incisions are parallel to the eyelid margin or along the lines of the orbicularis fibers, which also conform to the Langer's lines. But in the lower lid, this principle may be altered because you would like not to create any outward pull on the margin. So a defect like this would be converted into a vertical defect and closed vertically. If the defect is larger, you do not want to create any pulling. You need to replace skin either with a flap or with a skin graft. An example is an advancement flap after excision of a defect like this in the lower lid, where an advancement flap has been taken to cover the defect. Let's then go on to the full thickness marginal eyelid defects. Smaller defects up to 1/4 and even up to 30 to 40% in the older subjects can be taken care of by direct suturing, which may be helped by a lateral canthotomy and cantholysis, which essentially implies that we disconnect the lower lid attachments to the lateral orbital rim. This helps to do a direct closure. An example are small tumors here that we see. Once excised with a margin of about 5 millimeters, converting the defect into a pentagon shape, we're able to close it directly and get a comfortable, nice result. We'll skip this video, but we look at another video where the same technique has been covered. Where the defect is larger than quarter or 30 to 40%, you need to get anterior lamina from somewhere and you need to get posterior lamina from somewhere, or you need to get a combined flap from somewhere. So the anterior lamina may be obtained for those defects which are on the outer side by Tenzel's flap. You may take skin flaps from the upper lid region or from the brow region. You may use tissues for internal lamina alone from the other lid, opposite lid, or you may take the entire both laminae from the opposite lid by Cutler beard or inverse Cutler beard technique. The pedicle rotation flap of Mustarde is another technique which takes both the laminae from the lower lid for the upper lid. So let's look at this video where we have a congenital coloboma, which is typically in the medial part, but we are being able to use a Tenzel's here. We are making the margins raw and we are converting it into a pentagon shape. These are perpendicular to the margin and right up to the border of the tarsus. And then we make a semicircular flap, which is in line with the direction of the eyelid margin and extends not beyond the lateral orbital rim. We then do a lateral canthotomy and a cantholysis. So we are detaching the lid from the attachments to the orbital margin. And then we do an undermining so that the anterior lamina can be mobilized, the skin can be mobilized to convert into the upper lid tissue. So here we're doing the technique of marginal repair, which comprises the suturing of the margin by 3 vertical mattress sutures at the gray line, closer to the posterior margin and at the lash line. And then the tarsus is closed with vicryl, skin is closed with interrupted suture. And this is the new margin being created, incorporating the rotated skin tissue in the lateral part of the upper eyelid. And a vertical mattress suture is being used here to recreate the lateral canthus. It is important also to make sure that lateral canthus has a good attachment to the orbital rim and carry out a good skin closure and formation of the fornix here, so that the conjunctiva does not remain superficial. It must form a good deep fornix. So this is the principle that we use in Tenzel's repair. An example is this patient with a malaligned margin and a poor lateral canthus and this eyelid defect, where this technique has been used to carry out a repair and the reconstruction is completed. The skin flaps, a trippier flap implies that you take a flap with a pedicle from the upper lid and transpose it to the lower lid like this. And in a freak flap, you take it from the forehead region. An example is this patient with a basal carcinoma here and the defect after excision. We're taking a tarsoconjunctival flap for the internal lamina and we are taking a trippier flap from the upper lid for the purpose. And this is after we place the trippier flap in position, sutured the basic thing, the basic defect created in the upper lid. At the second stage, we have freed the tarsoconjunctival connection, and this is the final correction that we have here, and a good closure can be seen. The lid sharing procedures are good because they give a like tissue, a like internal lamina and a similar anterior lamina. But the difficulty arises in young children where it may cause stimulus deprivation, amblyopia. So let's look at some of the lid sharing techniques. The tarsoconjunctival flap technique is a very, very versatile technique which can be used for a defect like this involving the lateral canthus and the upper lid. This is a video of the technique for the upper lid, which gives us a good repair with a good margin lined by conjunctiva here with an adequate closure and adequate defect replacement. So this is an illustration of a basal cell carcinoma here. This is the defect. We have the cut part of the lacrimal canaliculus, which is marsupialized here. And then we've taken a tarsoconjunctival lamina for the lower lid here, as you can see here, from the upper lid, and then a trippier flap from the upper lid to cover this defect. And this is the result. Cutler beard procedure takes both the laminae. A defect like this, you create a flap which is about 1/4 size smaller than the actual defect, because that can be taken care of by direct stretching of tissues. So the two laminae are created and the internal lamina is sutured. The external lamina or skin muscle is then taken and sutured. So this is the kind of closure that you get at the end. And at the end of about 6 weeks, you can open it up, making sure you create the margin with conjunctival tissue. And you can get a very good correction, like in this infant with pre-existing opacity. So we could do a Cutler beard. Inverse Cutler beard uses the same principle for the upper lid, taking both the laminae from the upper lid, and provides, again, excellent results. Let's just look at in the end at the larger defects. Here, you need flaps for the skin, which can be taken by cutaneous, myocutaneous flaps of various kinds, internal lamina by tarsoconjunctival flaps, but very often you need support, which is more, and you need tarsoconjunctival and nasal mucocartilaginous graft. Of course, lid sharing techniques can still be used for 2/3 of the defects. For even larger defects, you may need temporal forehead or midline or glabellar flaps for the anterior lamina and the posterior lamina tarsoconjunctival or mucocartilaginous grafts. A few examples: a tarsoconjunctival graft is being used here. Rotation of the internal lamina can sometimes be used, as we have done here, and used a skin graft for correction in this patient. A Mastardis cheek flap is a large procedure where you rotate the entire skin from the cheek region, but you need to combine it with nasal mucocartilage. Periorbital flaps like the superficial temporal artery-based flap, because they contain vascular supply, can be rotated with a thicker tissue as is needed here. And for a defect, which is huge defect like this due to a delayed surgery in a basal cell carcinoma, can be taken care of by midline forehead flap like this, which can be rotated. But this needs to be combined with an internal lamina graft as well. Another example of a large temporal defect where tarsoconjunctival flap has been used, and this time a superficial temporal based flap from the outer aspect. So these are all illustrations of large flaps. Lastly, lateral canthal defects. It is important to carry out an attachment of tarsus to the periosteum. This is the vital element, and this is an example of an avulsed lateral canthus. And here we use double arm sutures with a suture like Prolene to anchor it to the periorbita and periosteum, as you see here. And these are double arm bites which help anchor the lateral canthus. This is an illustration of a defect involving the lateral canthus repaired with the technique we had outlined. And another one with a basal cell carcinoma on the outer canthus, repaired with internal lamina graft, anchoring technique as we have mentioned, to get back a well-formed lateral canthus. In the medial canthal defects, the important principle is that medial tarsus must be fixated to periosteum near the posterior lacrimal crest. So you need to, from the conjunctiva, expose the area behind the sac at the posterior lacrimal crest, where a permanent suture like Prolene can be fixated to the periosteum and to the medial tarsus or medial canthal ligament, tighten it to give you an appropriate correction. Illustration of a medial canthal avulsion repaired with a fixation of the tarsus and an advancement skin flap. So to conclude, eyelid repairs need to be customized based on the properties of the eyelid defects. Partial thickness defects can be repaired by simple closure techniques and sometimes flaps or graft, but full thickness defects require repair of both the lamellae, skin muscle, and mucosal lining. Depending on the size of the defect, the techniques vary. But what is critical is to do a precise reconstruction of the lateral and medial canthus. So a combination of techniques with sound knowledge and adherence to basic principles is integral to doing a good correction. Thank you very much.
Thank you very much, Dr. Grover, for a beautiful illustrative talk. We have Dr. Shubhra who has joined now, and Dr. Santosh Honavar also. Welcome and good afternoon. So Dr. Honavar is the senior moderator. So I hand over the webinar to Dr. Honavar right now. Hi, Shubhra, welcome.
Hi, sorry, I had a technical glitch at the last minute. I'm so sorry about it.
All right.
Welcome, Shubhra. Waiting for your talk.
Yeah, I'm so sorry. So can I go ahead with my talk?
Sure. Please.
Can you see my?
We can see the desktop, Shubhra. Maybe you might want to click on your PPT. Yes.
Maybe your connection is not too good.
Dr. Shubhra seems frozen, actually. It's, yeah.
It seems her internet connection is not too good even now.
Yeah.
Shubhra, can we defer your talk? Can you hear us?
Probably not, Dr. Grover. She looks frozen.
So can we then proceed with the next talk and have Shubhra come in after that? Next speaker is Dr. Marian Polly.
Yeah. Yes, sir. Hi.
I have a
How are
small
you? Are you ready?
a small announcement. We can hear someone's message beeping, the mobile. If everyone can put it on silent mode.
Okay.
Yeah.
Can I share my screen?
Yes, please.
Am I audible?
Yes.
Yeah, okay. Good afternoon, everyone. At the outset, let me thank Professor Grover and Dr. Feiruz for giving me this opportunity. And I appreciate the efforts of COC and KSOS behind this ophthalmology reboot. So, have been a wonderful program. So as we know, eyelid trauma is not a real emergency, but optimum, it is better to repair all the eyelid injuries within 24 hours. And it is essential that the patient and the globe be in a stable condition before acutely repairing any non-life-threatening or non-vision threatening injuries. So what are the surgical principles? We approximate the tissues as accurately as possible, close with the minimal tension, obliterate the dead space. Always layered repair is preferred, and obviously good lighting and hemostasis. Let us look into this patient. So in this, you can see it looks like a very ragged wound. We can see a bump here. So while we explore the wound, just look at the depth of the wound, extent of any tissue loss, foreign bodies inside, and if there is any fibrin clots, clear it up. And in this case, it looks like there is a tissue loss, but when you realign the tissues, it can be closed properly and nicely. This is the post-operative picture. So wound exploration is very, very important because once the injury comes, the orbicularis contracts and behaves like a tissue loss. So coming to superficial or deep laceration, but not involving the margin. Simple closure or layered closure. If only skin is involved, you can do a simple closure with the skin alone. If the muscle is involved, close muscle with absorbable sutures, mostly 6-0 vicryl, and skin with either silk or nylon or plain gut. Interrupted or running sutures, always try to avoid skin edges and make sure we should not close the septum because it can cause lag of ophthalmos. And if the wound is under little tension, we can undermine the edges, remove the sutures in 5 days' time. Coming to the lid margin, we know the anatomy of lid margin. There is a posterior edge, then meibomian gland orifices, gray line, then lash line and anterior edge. This anatomy is very, very important in attaining a very good contour of the lid margin. Additionally, the triple suture technique has been described. Dr. Grover has shown a nice video. So I will just highlight 1 or 2 points. This is a wound involving the full thickness tarsus and the lid margin. First suture is in the meibomian gland orifice. Far near technique. That is starting from far gland away, go far through the meibomian gland orifice, then come out through the near gland. This is the key suture which gives you the correct alignment of the lid margin. So once this suture is done, the lid margin is almost like you are safe that the lid margin will not have any problems. So that suture can be kept as a traction suture and suture the tarsus with absorbable sutures. Make sure the suture should be partial thickness and the knot should be on the anterior side. 2 or 3 sutures, at least 2 sutures can be taken to suture the tarsus. Then once the tarsus is closed, then close the orbicularis, again with absorbable sutures. And I prefer inverted sutures where the nodes come posterior. The orbicularis is closed with absorbable sutures. And once orbicularis is closed, you will get a nice apposition of the skin. So this here we can see that the skin is almost nicely approximated. Then we move to the lid margin to finish the other two sutures which Dr. Grover has already shown. So I'm not going into the details. And then you close the skin. So once the margin is done, the skin is closed and the sutures are tied over to the skin so that the corneal injury will be prevented. So these are some few pictures, that is 2 weeks post-op. Always will get a very nice margin when you do a triple suture technique. And this is a case where the tarsus is fractured multiple times. It was a grinding wheel injury. You can see the comminuted fracture of the tarsus. In this case also, each wound should be closed as with the 3-layer technique, and you will get a good contour and good result. Coming to the Canaliculus Repair, here the key point is find out the distal end of the canaliculus. So first dilate the punctum with Bowman's punctum dilator. I prefer mini monoca stent. The mini monoca stent is inserted. Finding out the distal end, I will discuss in the next slide. So once the distal end is found out, make sure it is patent, do syringing, then insert the mini monoca, close the pericanalicular tissues with the 7O vicryl, and close the lid margin in the routine fashion. So to find out the distal end, so I prefer to do under microscope. So you can see it is surrounded by orbicularis fibers, and in the middle of orbicularis fibers, where it is horizontal, there is a pink, pearly pink uniform, that is the mucosal surface in the middle of orbicularis muscle fibers. So this is actually very easy to find out the distal end if you look very carefully. Only thing, if the patient is coming very late, like after 24 hours, you have to really search till you can find out the distal end of the canaliculus and to get a good result. Coming to the levator, you suspect levator injury when there is ptosis and when there is fat in the wound. To find out identify the levator, grasp the levator and ask the patient look up and down. The levator will move along with the up and down movement. Once the levator is identified, suture it with absorbable sutures. Make sure you are not holding the septum. If you are holding the septum, you will feel a tug because septum is attached to the rim of the orbit. So you will not get that synchronous movement with the ocular movement. So this is a case of levator injury where you can see the patient presenting with ptosis. When you see such kind of cases, don't think it is due to the edema of the injury. Check the LPS action. In this case, the levator function was 0. So this was the presentation. While I explored the wound, you can see the wound is extending almost up to the fornix, and it is actually extending horizontally also through the fornix. So this is his postoperative picture. His levator has improved to 6 mm 3 months post-op. He needs a ptosis correction later. This is also another case. This is with the levator injury, 1 week post-op, almost total ptosis, and this is 2 months post-op with the mild improvement in the ptosis. Coming to eyelid avulsion. Here, in this case, this is a 6-year-old girl presented following bicycle injury. The lid was absent. So we asked the parents to go to the bicycle injury site and to try to find out the residual tissue if possible. So after 2-3 hours, actually they came back with the tissue in a gauze space, and then we have sutured it back, and it turned out very well. As we know this, we have published in Kerala Journal. If you are not able to find out the roused tissues, we have to reconstruct the lid as per Dr. Dover, which was seen in the last presentation. Coming to Canthal injuries, most of the time it is associated with the canalicular injury. In case of avulsion, suture to the periosteum with 4-0 non-absorbable suture. This is middle canthal avulsion post-op picture. What will happen if the puzzle is not solved properly? We can get lid notch, which needs sometimes with associated trichiasis, which needs correction with the wedge resection later. Can get lag of thalamus. This was presented 1 day post-op. You can see the lid lag and the minimal lag of thalamus. So I re-explored the wound next day itself. You can see that the septum was actually incorporated into the skin suture. That is why once the septum is released, the lag of thalamus got corrected. You can get anterior lamellar deficiencies. Sometimes primary skin graft might not be feasible. In that case, you can reconstruct later with skin graft. This is misalignment of tissues. So it looked like granuloma, but once we realigned, you can see once I removed that, see this is the original, this was the original wound. Canthal malpositions, if we don't close the canthals properly, you can get canthal malpositions, which also can be tackled later. Again, lateral canthals, cicatricial ectropion, which can be tackled later with Ectropion and lateral canthal realignment. So to conclude, excellent functional and cosmetic results are possible with the planned and meticulous surgical technique. And I would like to introduce this book where most of this, most of the faculty members are contributed in this, and will give a brief idea of eyelid trauma and other emergencies. Thank you so much.
Thank you, Dr. Marian.
Okay, thank you.
For a wonderful presentation. You have covered almost everything on eyelid trauma and reconstruction. Dr. Grover, are you there?
Yes.
Yeah, sir, any comments before we go on to the next talk?
An excellent presentation.
Thank you, sir.
The most important aspects are making sure that the marginal defect is taken care of well, the levator, if injured, is taken care of, and the canthal injuries are handled well. Marginal misalignments are the most difficult or most troublesome deformities later, and so are the canthal deformity. So this was a very adequate description of the techniques for taking care of them. Call upon the next speaker, Dr.
Annie. Dr. is still coming in. She will be here in another 2 minutes.
Should we wait or should I?
No, you can go ahead, ma'am, because we are at a time constraint, so it's okay.
Can you see me now?
Yes.
We put my timer. The timer. Okay, so I was asked to deal with lid malpositions. Upper lid malpositions can be ectropion, entropion, or lid retraction. And upper lid entropion is due to vertical shortening of the posterior lamella, the tarsal plate, conjunctiva, and upper lid retractors. And for the PGs, upper lid entropion is never involutional. So the treatment depends on the thickness of the tarsal plate. If it's a thick tarsus, you can do a wedge resection. If it's a thin tarsus, as in Steven Johnson or alkali burns, you have to do an anterior lamellar repositioning. So here, the lid is divided into anterior and posterior lamella. The anterior lamella containing the lashes, the orbicularis, and the skin. And it is separated from the posterior lamella by an incision along the gray line. This incision should extend across the whole length of the lid, but take care not to extend it beyond 1 centimeter from the medial and lateral canthi. And this incision is deepened and then taken out through earlier lid crease incision you have put earlier. And this incision is then extended laterally and medially. Again, take care not to go only up to 1 centimeter from the medial and lateral canthi. And then the anterior lamella is reposited further back on the tarsal plate, anterior surface of the tarsus, beyond 5 millimeter and sutured with vicryl sutures. And take care not to pass the sutures full thickness. So this is a post-op appearance, and you can see how it is. So if the tarsal plate is thick, you can do anterior incision of the tarsal plate as a triangle with the base facing anteriorly. And when you suture it back, the tarsal plate is it becomes everted, but this has a high recurrence rate. Tarsal fracture rotation can be done when you incise the tarsus full thickness along the whole length till you see the orbicularis, and then you put everting sutures. These sutures should not pass through full thickness of the tarsal plate again, and take it out near the lash line. So when you tighten these sutures, again the tarsal plate becomes everted. If the cicatricial ectropion of the upper lid, if it's localized, you can get away with a simple pentagon excision. But if it's generalized, skin may have to be grafted from the pre or post auricular area. And but the skin of the other eyelid is always a better match than the auricular area. In floppy eyelid syndrome, with the upper lid is lengthened, there will be lid eversion on sleeping in lag ophthalmos and dry eye. Here too, you have to shorten the lid with the pentagon excision. Dysthyroid ophthalmopathy, there's a lateral flare where the lateral part of the lid is above the medial. So you may have to incise the conjunctiva, molars, and the aponeurosis. If you have a cutting cautery, you can get a bloodless field. And here you can see after incising the conjunctiva, the molars, you can see the vertical muscles underneath this thing, and aponeurosis. You may have to do a full thickness aponeurosis incision to prevent recurrence of the lid retraction. So this is the post-op appearance. Lower lid entropion can be either involutional or cicatricial. So involutional entropion, PGs, you can take note, this is always a PG question. Involutional entropion can be due to vertical laxity of the lower lid retractors, overriding of the preseptal over the pretarsal orbicularis, which produces a band under the lower lid, interning of the tarsal plate, and there can be or no horizontal lid laxity. So always determine if it's cicatricial or involutional. Involutional, the lid returns to normal after eversion, and in cicatricial, it returns to the inverted position after you evert the lid. So, and always look for do the snapback test and look for vertical laxity, and do a lateral excursion of the punctum to rule out horizontal lid laxity. So in Jones plication surgery, which is usually done, and here by plicating the retractors, you can correct the vertical laxity, and overriding of the orbicularis is prevented by the barrier of the suture. The suture bite taken through the lower tarsus prevents the inversion of the tarsus, and the horizontal lid laxity is corrected by either a lateral tarsal sling or a pentagon excision. So here, always before you start surgery, check for the horizontal laxity. Through a subciliary incision, the orbicularis is retracted back till you reach the inferior orbital margin. You can see the vertical retractors are thinned out, and you can see the cornea through that. So the plicating sutures are placed first through the orbicularis, and then 2 bites are taken through the vertical retractors, plicating them, and the last bite through the lower edge of the tarsal plate. And as you pass through the tarsus, you can get a gritty feel. 3 such sutures will have to be passed. And the second suture, you may have to fish out the vertical retractors from the depth of the incision. And at the end of surgery, you have to aim for a slight eversion of the lid. The skin is then closed. If you have horizontal laxity, you have to shorten the lower lid by again shortening the tarsal plate first, suturing it to the lid margin with a non-absorbable suture, and then shortening the skin. So this is a result after LTS and Jones procedure. If there is acute spastic entropion after trauma or surgery, you can put everting sutures where double-armed vicryl sutures are placed from the lower fornix out through the skin at the lash line. So again, 3 such sutures have to be passed, and sometimes this result can sometimes be permanent. You may not have to repeat it. In cicatricial entropion of the lower lid, you may have to excise the scar tissue and do a mucous membrane graft. Here, 4 mm below the tarsal margin, incision is given on the conjunctiva and the lower lid retractors, which are released, and you may have to place a spacer in between the near the conjunctiva. For this, I've taken a graft from the lower lip mucosa with fibrin glue. Involution ectropion of the lower lid can occur in young people where the lower tarsus is not attached to the lateral orbital margin. Here too, you have to tighten the lower lid and with a lateral tarsal sling. In such cases, sometimes ptosis may also be associated. Here, a lateral tarsal sling. Here again, the lateral part of the lid is separated into anterior and posterior lamella, and the tarsal plate is tightened separately from the skin after debriding all the epithelium from the tarsal margin, and again the skin is excised. I cannot show the full video because of time constraints. This was another case, post-op appearance. In epiblepharon, you have to excise a sliver of orbicularis and skin and then fix it to the tarsal plate. Blepharophimosis medial canthoplasty is done at 3 to 4 years of age, followed by sling after 3 months. I do usually after 3 months. But if this ptosis is severe, the patient sling can be done when the patient sits up to prevent amblyopia. In plexiform neurofibroma, vertical and horizontal lid shortening will have to be done, followed by sling. But if it's a mild case, you can escape without a sling. Upper lid colobomas can be freshened up. Dr. Grover had shown a very good video, and a small tensile flap was only necessary, but sometimes even primary closure is enough to close even large colobomas. Thank you. Thank you, Feroz. Any questions?
Thank you, Dr. Sridhar. That was a very beautiful coverage of a vast subject within 10 minutes.
Okay. Finished on time.
அம்மா நான் மீட்டிங் கேட்கிறேன் அப்புறம் வா சொல்றேன்.
இது சோமல ஸ்டாப் ஷேர்.
Dr. Lakshmi, you're muted. Dr. Grover, do you want to introduce Dr. Lakshmi and go ahead?
Now இப்போ PowerPoint open பண்ணிருக்கேன். What I should do?
Any discussion on Dr. Annie's? Dr. Kasturi, any comments from you?
Very nice presentation, Annie. I really appreciate the way
Thank you.
The very, I mean, worst cases of entropion and ectropion.
What is the most point?
On the Jones very nicely, especially the plication of the lower lid retractors. But what I think that the lower lid retractors really play a very vital role in the functioning of the lower lid. I think Lakshmi Madam is here. We can discuss more about it if we get time.
மியூட்டா இருக்கேன் போல இருக்கு. மியூட்டா இருக்கேன்னு நினைக்கிறேன்.
Ma'am, you are not muted. We can.
You can hear me? Okay.
Yes.
Good afternoon, everyone. At the outset, let me thank.
Your slide. Slide?
Yeah, slide is.
Is it the first slide? Introductory slide?
Okay. Do you see my slide?
Yes.
Yes, ma'am.
Okay. At the outset, let me thank Fairuz, Dr. Gopal Pillai, Cochin, and the Kerala Ophthalmic Society team for this wonderful show. I've been asked to cover on the management of ptosis. You know that this is again a very vast topic, but let me try to do the whatever best I can. Classification is congenital and acquired, as you all know. And in the congenital variety, we have simple and complicated. And acquired, you have various causes, and sometimes you can have a combination of these causes, right? Decision making is a very important aspect of ptosis correction. One has to have a detailed history. We'll have to, if it is a child, we'll have to confront the patients and parents and ask them repeatedly, because we should not have an unhappy patient or parents at the end. Old photographs is very important in older subjects, because many a time they come in the third decade when they want to get married and settle down. So it's important to get a very good history before you go in for surgery. Of course, levator muscle function and protective adequate eyelid mechanisms, protective presence of this is very important. That is an important aspect, is a good Bell's phenomenon. If you don't have this, then we have to face several consequences. Important test, as you all know, is the Burkitt's test, then the Bell's phenomenon, and the levator muscle function. These are the three important tests. And of course, the ellipse sign is one which tells us whether it's congenital or not. As a rule, it still holds good, but many a time we tend to differ as we see more and more patients and handle more challenging cases. If the levator function is more than 4 millimeter, we do a resection. If it's less, we do a sling. But of course, there are always exceptions to the rule. But this is the standard teaching. Now, when we have a case of congenital ptosis, we have to operate as early as possible to prevent amblyopia, as we all know. And we should tell the parents, or if the child can also understand, or is a teenager, that the presence of lid lag and lag ophthalmos, because this is very worrying. You may have a very good correction, but this is something which we should prepare them well in hand, so that they are able to tackle it for some time in the post-operative period. Luckily, it settles by 2 to 3 months' time. But sometimes when we have done a maximum resection, or we have done a supramaximal or corrected it a little more than adequate, though the correction is very good, it may linger on for some time. So you may have, the parents may have to take care, apply lubricants. The child also has to be aware of this problem. We don't want to have corneal complications. Complicated, you have various causes. Just let us see a few of them. If you have an associated squint, it's better to do the squint surgery first, then go for a ptosis correction. When we have bilateral ptosis with very poor function, and when it's very difficult to communicate or elicit the function of the muscle properly, then it's better to go for a bilateral sling. But these days, we are more in favor of a good resection. Now, very many a time we get video consults, earlier we were getting mail consults. When you see a case like this, you know very well that we have to first refer it to the squint colleague to do the correction and see if they can, little bit of superior rectus function can improve before you do a ptosis correction. Because many a time when they come down without, if you have not told them this, they get very disappointed, especially if their patient travels from far. Double elevator palsy, said it's a sling surgery, but when the patient comes, this patient had already had a correction for squint, but still she had poor mechanism. So further squint correction was done to improve the superior rectus function. And telling her all the precautions, levator resection was done, and she did develop a little bit of corneal problems in the post-operative period, which was managed adequately. Marcus gun phenomenon, earlier we were doing the two-stage procedure, but these days, if the child can understand, and if the levator function is good and there's no amblyopia, we would like to wait before we just do a single stage procedure, rather than do a double stage where we completely recess, close the eyelid, and then do a sling. Many a time, parents are also not very keen on having this double stage procedure. Of course, it all lies in how you convince and what you are happy and comfortable. But nevertheless, if we can get away with one stage, better, rather than two-stage surgery. Of course, in blepharophimosis, Kasturi is here, she does a single stage, but the standard teaching and what we generally do is we like to decrease the telecanthus in the first stage, wait for about 3 to 4 months, then we go ahead with the sling surgery for the ptosis. And in telecanthus repair, I've tried many things, but in a later age, provided maybe we could just get away with a YV plasty or a double Z plasty, but in a younger age group, I like to do a double Z plasty with a transnasal wiring. I like to use 4-0-proline and do the transnasal wiring, where this proline, unlike we were using steel sutures in the past, unlike steel, doesn't exteriorizes lesser. Nevertheless, we must make sure after the transnasal wiring, you can use a beautiful awl which some of your plastic surgeon colleagues may have and use that instrument. Earlier, we were even using Venflon needles and things like that before we could get hold of this instrument. It's a little messy. You can use the drill, but if the nose is already very flat, and if you're doing it in the Eastern Asians and things like that, then it's a little bit risky. You don't want to go near the cribriform plate. So you could use this beautiful instrument, the awl, and maybe a proline suture, but make sure when you tighten the two ligaments, you bury the knot well so that it doesn't exteriorize. Reoperation is generally needed in about 30 to 40% of congenital ptosis, especially when they attain puberty. But sometimes we have to reoperate within a few months or a few years itself. This is again important to tell at the council at the time of surgery. This was one such child where I did it when she was around 5 to 6 years old, and she came back when she was 14. I had to revise one eye, and that is the right eye, but the left eye, whatever I had corrected earlier, was enough. So it does vary, and this result is really very, very elusive. It is really difficult to predict. When you have oculoplasty fellows, when you train in oculoplasty, you may even do very good orbitotomies, you may do exentration, but ptosis surgery is something which is really difficult, and we have to keep on learning, and we are still learning. Of course, other causes like allergic conjunctivitis, which cause mechanical ptosis. I mean, luckily, we don't see much of hard contact lens disease, but some semi-soft lens wearers can have severe allergy and some ptosis. So we will wait for those factors to be corrected before you try to go in and operate. So you have to give the levator some time for other aliens or other irritants which have caused the function to be less before you embark on surgery. Usually in these cases, the levator function will be good, and there will be usually only a levator dehiscence. You may have certain tumors. It's very important to evert each and every eyelid. Eversion is a very important aspect in all our oculoplastic procedures. Blepharochalasis, we had one beautiful case which Kasturi showed along with lacrimal gland prolapse. Again, we should have an interval-free period of at least 6 months to 1 year where inflammation has not occurred before you do the ptosis. Be careful, even though the skin looks very wrinkled and little oldish type. Sometimes I have had instances where I had to put back the skin which I excised on the table because of shortage. So even if you're taking off a little bit of skin in ptosis, make sure you keep it in the fridge, wrap it in wet cloth, and keep it for at least a week or two until the wound heals to see if the patient is developing severe lag ophthalmos or not. In congenital ptosis, I don't even excise even 1 millimeter of skin. Very, very rarely I take out. Every millimeter of skin and is important. And cases like blepharophimosis, there's already a shortage. So you can't afford to take out any skin. Mechanical tumors, again, you have to treat the cause. And that's again importance of eyelid avulsion. Here there was a cyst which was causing the ptosis. This has to be tackled and wait for about 4 to 6 months, see if the levator function improves, then go ahead. Myasthenia, if you ask me in one word what you like to do, I just don't want to do surgery. Because over the years, I've realized medical treatment is best, even if they have stable and you do a limited sling surgery. Sometimes after 10 years, this patient is almost like on a 22-year-old follow-up. Again, it recurs. So I think medical management is, as far as possible, is best for myasthenia. Of course, we are seeing a lot of thyroid issues. We do see thyroid with ptosis in myasthenia patients. So we have to be careful, and we have to tell them that the eye will look a little prominent, sometimes So you have to tackle the eye disease, thyroid eye disease first before you do that, because then you don't want to land up with an asymmetry again. Traumatic third nerve palsy, again, best not to operate. Crutches are the best, but if at all you're doing surgery and if there's a little bit of flicker of bells, do a limited sling. So crutch glasses, most of the cities or some of the good opticians, you can work at very nominal prices, because these tend to become a little firm and hard, and these have to be replaced. But once they understand the importance of these crutches and you counsel the child or the adult well, usually there is very good compliance. Familial history, again, as I said, was so important, because you have to ask whether it's running in families, consanguinity, examine, they may have other syndromes. So here it's best to see how much you can defer and treat the amblyopia and keep that under check before you do any surgery. Acquired ptosis is a big thing. Shubhra and Kasturi and Dr. Grover sir all will agree with me that I think among all the cases, these are those, and at least in congenital, you can tell them it will acquire, you can get it back when they attain puberty. But here, you have to be really good. You have to be very patient. You may need several sessions. I've brought in some of the slides of my very difficult cases, because some of these patients are all big shots and they don't want their faces to be seen, but they're really huge expectations. They need so much of counseling. So I think that here is where the real test lies.
Something has happened to network.
Monitor, talking to them, and assessing. We can make the patients sit 45 minutes, may be able to make it. I don't think, especially under mild sedation, you can sit 2-3 times.
I think she got disconnected.
She is
So
connected,
she's still there.
but something is wrong.
Yeah, probably connection. So that was a very illustrative talk of all aspects of congenital and acquired ptosis. And it's a huge task covering them in 10 minutes. I think she's highlighted all the important points. She's highlighted all the essential techniques that we use in congenital ptosis. I think evaluation is the key, which decides what procedure to undertake and at what stage and what age.
The internet connection is unstable in Varda.
Yes, Dr. Lakshmi, would you like to say something to conclude?
Sir, can you hear me now?
Yes, we can hear you.
Yeah, just I have 2 more slides. I'll quickly finish off. Blepharoplasty, of course, you can do the combos. And here is a very small gist of what all I spoke. It's complex etiology is there.
The slide sharing is not.
Can you reshare the slides?
Okay. Reshare the slides in Varda. No, it's not coming there. I cannot see.
I think you can summarize without the slide then.
Yes, ma'am. We cannot see the slides. But we can see you.
Yeah.
No, they cannot see this. Only me they can see.
I think you can summarize it.
Okay. I think I'll end there. I just had a couple of more slides. I had one slide of Dr. Nirmala Subramanian, whom I can't thank enough, who is my teacher and mentor, who taught me the beautiful art of ptosis surgery. Thank you very much.
Thank you, Dr. Lakshmi. That was an excellent talk covering all aspects very well, including the congenital and acquired. 10 minutes is a very small time to cover a huge subject like that, but you did cover it very well. So Dr. Santosh, would you like to say something, add something? Or Dr. Kasturi?
So nothing much. She has covered the whole subject very well, right from all the congenital to the acquired and the difficult acquired situation. And she has very rightly mentioned that the acquired ptosis are at times more tricky than congenital ptosis because they're more demanding. Everything covered very well, ma'am.
Thank you, Kasturi.
Okay, then we'll go on to the next talk, which is by Dr. Reena Rashid. She talks to us on eyelid bumps and lumps. Dr. Reena, please, can you start your slide share?
Okay, sir. Thank you, sir. Good afternoon. Thank you, KSOS, COC, and Fairuz for including me in this session. My talk is on eyelid lumps and bumps tumors. So we know that it is a specialized region in ocular adnexa with multiple tissue types. Because of this, I can get a wide range of tumors which may occur in the eyelids. Am I audible?
Yes, although sometimes the voice is breaking. Generally, you are audible. It's okay. You can continue.
Thanks. So the tumors can have a highly variable presentation in the eyelid, and they can range from benign to pre-malignant to malignant tumors. And based on the tissue of origin, the variety of ones, which I am not going into, a more clinical approach will be easier to have a diagnosis in eyelid tumors. The infantile capillary hemangiomas are one of the commonest vascular tumors that you will see in eyelid in children and infants mostly. There can be a superficial periocular lesion, or sometimes there can be a deeper element. With the introduction of oral propranolol, we know that the response, so it has completely revolutionized the treatment. No, we no longer do any interventions for these capillary hemangiomas, even in these huge ones with orbital component. You can see that often in this particular patient, I have combined it with the topical beta blockers. And only thing is that you have to be aware of the complications of the side effects of propranolol. So you have to consult with the pediatric oncologist before starting therapy, and the parents should be warned of the complications. Now, these kind of vascular tumors can have a nodular appearance with some kind of a discoloration, especially when it is a deeper lesion or a subcutaneous lesion. Has a swelling which is soft and compressible with some bluish discoloration of the skin. Many of these patients can have associated arteriovenous malformations elsewhere in the body, which has to be evaluated. Now, venous malformations or low flow venous malformations are very rare in the eyelid, but they can ptosis. So the mechanical ptosis, if you are not picking up, you can, or if you are not doing the Valsalva's procedure, it may be mistaken for other forms of ptosis, which we've already heard. And also in all these patients, you can see that it is getting up on exertion or on Valsalva's maneuver. High flow AV malformations are very rare, but these are. This is one case I have seen, and these patients often do have functional impairment because of the heaviness of the flu and all. If you do a digital subtraction angiography, if there is a occludable feeder vessel, then pre-embolization followed by excision can be a treatment of choice. But most of these patients, after explaining the possible life-threatening complications, they do stay away from the surgery, and this patient is kept under observation. Now, coming to more diffuse and ill-defined tumors of the eyelid, this man had a fullness of the eyelid in the lower part. That is all he had, and this was a pseudo-encapsulated tumor, so I could completely remove the tumor. And in these cases, sometimes there can be associated eyelid malpositions, like you see in the other lady who has an Ectropion and laxity of tissues so much around. So when you do the debulking of the lesion, you can also correct the eyelid anomaly along with this. And this came out as a myxomatous tumor, and the other one was connected with the inferior rectus muscle. When you think about diffuse tumors of the periocular region, the most common is plexiform neurofibromatosis. When there is an extensive facial component, there is no difficulty in diagnosis. But in that young man, you can see that there is only diffuse thickening of the eyelid. This patient was on treatment for blepharitis with so many antibiotics from many centers. Finally, before he underwent a biopsy and confirmed the diagnosis. Now, even in eyelid lesions, when it is a diffuse lesion, especially when the outlines are not clear or posterior extent cannot be seen very clearly, you have to do imaging. And you can see in this young girl who has a small diffuse swelling in the eyelid region with no proptosis. So in the imaging, you can see a huge lesion extending into the inferior orbit, which came out as lymphangioma. And also in this young boy, you can see that there's a typical occasion. You can make the clinical diagnosis of dermoidosis, but again, before deciding treatment, you have to do the imaging to see any intracranial extensions or defects in the bony part. Now, again, when you think about diffuse and eyelid tumors, which are firm or soft form in consistency, the most important is ocular adnexal lymphoma, where eyelid alone can be a location for the tumor. So these tumors usually feel a little more rubbery in consistency, and sometimes when it is arising from the fornix, they do give a fullness of with some amount of mechanical ptosis. And here, in all these cases, you have to go for biopsy. And depending on whether you can remove it completely or whether it's a wedge dissection, and then send for a histopathology and immunohistochemistry, type it, and then do the treatment. Coming to more benign, soft and cystic swellings in the eyelid, which are having a content inside. These are simple innocuous swellings, cystic swellings with a clear or translucent or turbid fluid inside. Most of these are seen in children following trauma or following an membranous conjunctivitis. If you simply aspirate the swelling, it will refill. So you have to excise this again. This an 11-year-old who had history. She had primary repair at primary hospital. She had 2 more, and the wound was never healing, so she had 2 more explorations done. But she carried a CT scan also at the time of trial. But this is how it presented: an abscess in the eyelid and a discharging sinus in the forehead, which occasionally rupture and pus will come out. Even in MRI, we couldn't identify a retained foreign body, though we suspected it. So with a high index of suspicion, we explored the wound, and this is what we could remove from the eye. So you should remember that organic foreign bodies are very difficult to identify even in any form of imaging, and high index of clinical suspicion is all that is useful. Now, coming to more firm and nodular type of localized eyelid lesions. These are very common, and often these are mistaken for chalazion, and they can assume various shapes and sizes. And if you do a simple incision and curettage, they will recur. And if you when you do the INC, you can see a cheesy material coming out as different from an chalazion, and you have to do a localized tasectomy along with some cauterization of the edges, and maybe a short course of steroids systemically if there is recurrence. Now, we know that about 20%, 15 to 20% of these periocular lesions are malignant, and they can masquerade as so many different forms. And about 5% of these malignant lesions can metastasize also. And there is a geographical variation. As we know, we are in our part of the world, it is sebaceous gland carcinoma that is more common than the basal cell carcinoma, which is very common in western parts of the world. And this sebaceous gland carcinoma can have a nodulo-ulcerative or an infiltrating presentation with varying types of clinical manifestations. These sebaceous gland carcinomas can arise from the caruncle also, and these tumors are often highly aggressive, and they can spread very fast into the nasal cavity, sinuses, and also to distal metastasis. So whenever you see a similar case like that, you have to see the swelling under eyelid margin and the swelling under the slit lamp and look for atypical signs. And these atypical signs can range from loss of cilia, abnormal lashes, so telangiectatic vessels, a widening of the lid margin, loss of meibomian orifices, or sometimes thickened or widened lid margins. And many times the swelling will be larger than the size of the height of the eye tarsal plate. And sometimes you can see puckering when there is infiltration to deeper tissues. And always look for any regional lymph node enlargement. So when you're missing these subtle clinical signs, you may be doing an INC or sometimes a simple excision, and the patient will come back with recurrence. And this is one patient who had a third recurrence following multiple excision tumors without following the principles of malignancy. Now, this is a relatively young lady who had multiple INCs, and this is how she presented: a huge swelling involving the tarsal plate, which is having spontaneous bleeding even on eversion. And this she had enlarged lymph nodes at the time of presentation. So whenever you see a similar lesion, you have to identify the extent of the lesion by doing a slit lamp examination, because it will be extending far beyond the clinically visible swelling. So that based on the extent of the lesion, you have to decide the type of reconstruction and wide excision that you are planning. So this is very important to document the extent of the lesion. Now, the surgical principles already discussed in detail. Now, if these surgical principles are not followed, that is, if you are getting making sure that you get a clear margin of about 4 to 5 millimeter all around the tumor lesion before reconstruction and sending it for histopathology. If those surgical principles are not followed, or if you ignore, these tumors can locally metastasize into the orbit and can present like something like this with a frozen orbit, and especially when the patient is having vision. Sometimes these tumors can acquire very huge sizes, which are then managed only by accentration, even that with some difficulty. So that is all about lid tumors. Thank you.
Thank you, Dr. Reena. That was a very extensive coverage of all the different types of tumors, malignant, non-malignant, and taking care of it in a small, limited time is really very good. We really enjoyed that. We now go on to Dr. Shubhra. Dr. Shubhra is now available, and Dr. Shubhra's presentation is what we'll have next. She is one of the pioneers of aesthetic oculoplastic surgery in the country, and she started the aesthetic work while she was at Shankanetralaya. She's now in Hyderabad, and we look forward to listening to her speak on fillers. Shubhra, welcome.
Thank you very much, sir, and a very good afternoon to one and all. I'm sorry, I think by mistake I was removed by the host, and that's why this screen was not sharing. So we are all sorted. I think the Feroz would be controlling my presentation, and I would be presenting from my mobile through the audio. So that's how we are doing. So technology at its best. Thank you so much, sir, for the kind introduction. And I don't think I'm the pioneer. I think amongst you, Dr. Kasuri, Dr. LM, and everybody senior out here, I don't take that credit at all. So Feroz, can I have my presentation, please?
Going ahead, I'm sharing the screen now.
Thank you so much.
Is the screen seen?
Yes.
You can just go on the play mode. Yeah.
Okay.
Perfect. Thank you so much, Feroz. So my talk is to excise or to fill. Now this kind of becomes a very valid kind of a decision maker when we are dealing with upper and lower eyelids, fullness or hollowness. So when you see certain patients who walk in, you can have patients who walk in with different kind of complaints or errors around the eye, which is both upper and lower eyelid. As you see in these pictures, all of them have the lower eyelid, puffiness or wrinkles. Plus, they have issues with the brows and the upper lid skin. So, to kind of elaborate on each picture, if you see the first picture is a lady who is around 35, 40 years old, and she came to me for blepharoplasty. She's a doctor by profession. And if you really look at her periocular area, she has brow ptosis with, the affected eye having mild ptosis with lower lid bags, which is grade 1. There is a mid-face ptosis and hollowness. If you see the gentleman who's in his 60s, he has grade 3 to 4 eyelid bags. And the girl below is a girl who had procedures before, and she is not happy with what has been done because there's a lot of rhytides around her lower eyelid. Next slide. So the question is, insert these patients when they walk in, how do you make a decision? Next. Next slide. Yeah, so these are my financial disclosures. Next. So everything when we take a decision is based on two concepts, which is, next, volume loss or gravity and descent. Now, what do you mean by volume loss or gravity and descent? Now, if you look at the face, where everything which is present, which is kind of volumizing when we are young, it goes and depletes itself as we age. And along with that, there is also the descent of tissue. So it's very, very, evident that if there is a volume loss, even if you pull and lift the tissue, it's not going to make any difference. So when there is a volume loss, we need to fill. And when there is gravity and a descent, you need to either lift or excise the extra lax tissue. So the decision mainly is based on these parameters. Apart from that, when we look at the face has to be looked into a three-dimensional, profile and not as a two-dimensional profile, because that kind of changes the decision-making which we are doing. Next. So everything depends on this concept of theory of deflation or volume loss, as I mentioned. As we are progressing in our aesthetic practices, we are understanding that the skeletal network and the ligament support, which kind of lifts the fat pads and supports the muscle, is the most important, or the baseline or the anchor or the foundation on the face. So it is very important to first volumize and then go ahead with any kind of excision or lifting. Next. 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 So I think the slide just went off. That doesn't matter. But, we look at in aesthetic practice, or one of the concepts which we look at is, if you compare the face with a house which is under construction, you can consider various parts of the house under construction, in form of the areas where you want to correct it. So, for example, your ligaments are your pillars, and your bricks become your cementing or the fat pads. And then you have the structures which are filled in, which becomes the fat pad or the volume. So unless your base or the ligament or the support is not strengthened, no matter what we do, the structures would not lift itself. So this kind of makes the basic concept of excising or filling any part of the tissue on the face, and especially the periocular area. Next. Feroz, you can just go next, because it's a multiple slide. So what I mean by, excising is blepharoplasty. I'm sure Dr. Kasturi has beautifully illustrated excision versus redraping of fat pads. Now, I personally don't do that much of redraping of fat. I'm more into filling up with fillers, though redraping is a wonderful technique, and Dr. Kasturi has some fabulous results, and I'm sure she's shared with you. So this is what we mean by excising the tissue, which is in the form of blepharoplasty, both for upper and lower eyelid. Here, the picture depicts the lower eyelid, where we are just I wouldn't say excising, but sculpting the fat which is in excess. And then we do a pinch technique to remove the extra skin. Now, redraping of the skin can be done in people who have excessive laxity, and that becomes a different technique when we are dealing with such procedures. Next. So when we are looking at the eyelid and the mid face, it is one junction, and we cannot deal with it in a different as different anatomical units. This is just a schematic picture which we usually take as a baseline when we are doing our fillers, but I would just use this picture here to explain that when we are dealing with any kind of lower lid rejuvenation, it includes the rejuvenation of the mid face and the zygoma. So the point number one is your zygomatic prominence. Two is your, the malar prominence, which also includes your malar fat pads. And three becomes your medial area along with the tear trough. So if we don't deal with these three structures, whether we are doing surgical or non-surgical, rejuvenation, it does not give a foolproof result for any technique. Next. Next. Yeah. So this was a gentleman. If you look at him, he's around 90 years old. He's 90 years old, and he complains of obviously heaviness along his lower eyelids. Now, everything is saggy and descending along with the volume loss on his face. But the minimal is what we can do. And the main complaint he had is that he's not able to, tolerate his glasses. When he wears glasses, the fat pads in the skin is hitting it. The sweat is getting collected, which also is quite a common complaint in a lot of patients. So we just went ahead and did a little bit of sculpting without any skin excision. The reason being he was also on anticoagulants, and we didn't want to do anything very aggressive, and we just did a sculpting, and he was pretty happy with the result. Next. So this lady obviously has grade 2 medial fat pad prolapse. Now, in present situation or in present practice era, I would actually be very happy to go ahead and either redrape her fat, or we go ahead and fill the tear trough area, the zygoma, and the malar hypoplastic area, the hypoplasia area. But this lady was very keen on surgical intervention, and we just went ahead with transconjunctival fat sculpting with no skin excision or redraping, because she didn't have an excessive skin which was there. So we just went ahead and did a little bit of fat sculpting, and the result was like this. Next. I think, okay, so I don't think we saw the post-op, doesn't matter. Yeah. Yeah. So this is what she looks on day 3 or day 4. So if you really ask me, do I like this result? Absolutely not, because this is not one of my best results. If you see, don't look at the scars, because they would heal. But what happens, and what we have repeatedly looked at, is when we do a fat sculpting, as in liposuction, the body fat redistributes itself. Even in lower lid, the fat redistributes itself. And if you just sculpt one pocket, the other pocket pushes out. So this was a learning lesson for me, where it is very, very important for us to understand that even if there is a single unit fat prolapse, we need to kind of deal with the lid cheek junction in toto. So this was not one of my best results. But yes, if you ask, that patient was happy, yes, she was happy. But in the aesthetic, kind of result profile, I wouldn't be very happy with this result. Next. Yeah, so this was the gentleman, I just shared the picture. So in such examples or such cases, we don't have to really look at the cosmetic outcome, because these patients are not really concerned. What they just want is a structural unit which is not looking good, and they just want to get rid of it. And this kind of becomes easy, where we do an open Sky Blepharoplasty, where we go from the skin side, remove the fat pads and remove the extra skin and redrape it. And this is how the patient gets his result, and he's pretty satisfied and happy about it. Next. Now, coming to upper eyelids are tricky. We have to deal with them as we deal in lower eyelids with the lower lid and the cheek junction. We have to deal with the upper eyelid along with the brow. So obviously, I'm not going to go into detail of it, but we need to look at the brow ptosis, the dynamics, and yes, go ahead with either the lid, the skin excision, or plus minus fat excision. There are cases, very rare cases, where you would find hollowness, except that cases which have been operated before where you may have to fill it. Otherwise, upper lid is pretty simple and straightforward, where you do a brow lift plus minus, blepharoplasty plus minus, brow lift or brow pexy. So this was one of the cases where there was an asymmetry of eyelids, and we went ahead and just kind of symmetrized it and removed the extra skin. And this is how she was pre and post. Yeah, next. Yeah, so this is how she's pre and post, and you can see the facial features completely change itself once the upper lids are handled. So I'm just going to share, I think, one more example. So this was, upper lid blepharoplasty. Now, these are the patients where definitely there is no need to go and excise, because there's, it's very evident that these patients have volume loss. You can see she again has a grade 1 fat prolapse, but what is more prominent is the hollowness and the mid-malar, the mid-malar fat atrophy. So we went ahead and did the 1, 2, 3 points with fillers. Next. So this is the pre and post, where we kind of augmented the whole lid cheek junction, and the result looks pretty fine. Next. So another lady, I think, so she came with the idea of blepharoplasty, and I kind of said, you know what, let's just go ahead and fill this area, because I don't think you would do good with blepharoplasty. The reason being, if you really look at her, it is more of a fact, there is not much of a sagginess which is present. It's more of a volume redistribution which is required. So we just went ahead and played around with the fillers with the selected points. Next. And this is what we achieved. Now, yes, we can always go back and do a little bit of skin tightening or skin resurfacing later. But as long as the patient is happy about the results, we go. I personally go a little slow on such cases and let them come back to me when they want anything extra. Next. Yeah, another case where complete, the valley hill effect, which can be seen, and this is a definite case of filling. So we went ahead and did the dermal fillers along the lid cheek junction, and this is how the result was. Next. Yeah. So this was a little overexposed picture. Yeah, this is me. I just wanted to show my picture because I just took, these are selfie pictures, by the way. I just took it myself to just kind of understand, what happens when, we kind of play around with fillers on our own face. If you look at my face, there is a grade 1 mid-face descent. There is a tear trough, which is grade 1, and I do have a brow ptosis and an upper lid dermatochalasis. So we didn't do anything on the upper lid, but I just went ahead and did the fillers on my mid face and the tear trough and along the jawline. And this is how I looked after the fillers. Yeah. So though I am animated here, but you can see the lid, the malar mound is much more prominent. The cheek hypoplasia has gone down. It looks more rejuvenated. The jawline is much more slim and pulled up because the jowl effect has gone down. But because the upper lid was not tackled, I think there is a scope of improvement. And this was done, I think, 2018 or 2019. And I haven't done fillers after that because we were discussing this yesterday, and I'm one of those patients who develop the delayed hypersensitivity reaction to fillers, and I kind of bloated up after the fillers, so I've kind of stopped doing it. So yeah, so this is how I changed after fillers on my side profile. Next. So another example, next, where we did the full face along with the lid cheek junction to give her a rejuvenated look. Here around 5 to 6 cc's of Juvederm was used, and we kind of mainly worked on her mid cheek, lower cheek junction, and a little bit on the jawline and chin. Next. So these are certain examples where we just played around with filling effect and remodulating the face. So these are pre and post where we can just reshape the face and do, and mainly working around the periocular area, and a little bit around in the lower face if need be. Next. So yeah, multiple. Yeah. So this is my, I think one of my last slides. This was the lady who presented to me where the fillers were done elsewhere, and she came back with the lower lid Uveitis. The problem which was happening was there was too much of overriding of her inferior orbicularis with fullness on the cheek. So we went ahead and dissolved certain product, give her a little bit of Botox to relax her orbicularis, and redid a little bit of, volumizing at the tear trough area. And I think the results were pretty okay. So next, so yeah, to reiterate my points, whether we need to excise, we need to fill, or we need to paralyze, it all depends on in what structure the house is, whether there is a volume loss or a descent. And we kind of play around with these principles and sometimes do a standalone procedure or sometimes combination of procedures. Next. Thank you very much.
Thank you, Shubhra. That was excellent. It gave us a good overview of when to do what kind of procedure. You have to be very judicious. You have to develop the right judgment at looking at faces and assessing what needs to be done in a given case, what is happening to the volume, whether the addition is the right course to take, or whether some kind of trimming, as she said, is what is indicated. Excellent talk. Thank you. We enjoyed it. Very nice results.
Thank you so much. And thank you, Feroz, for being my fingers. And thank you all for being patient. I'm extremely sorry for this glitch today.
And next is the savior herself, the dynamo of energy, Feroz. She is our voice. She has given us voice in the scientific committee of All India Ophthalmic Society. And she organized that wonderful international webinar yesterday of X-Files cases. And now we want her, and she's the organizer of today's program. We look forward to her speaking to us on orbital inflammation, the twist in the tail. Let's look at the twist.
Thank you very much, sir. Thank you so much. I'm going to share my slide now. On the outset, I thank Dr. Gopal and the Cochin Ophthalmological Club for giving this wonderful opportunity. And so my topic for today is orbital inflammation and few tales associated with it. I have no financial disclosures, and these are my affiliations. All right. So basically, the few slides, I'm not going too much into the theory, but I'm sure the postgraduates and the residents are there. So whenever we talk about orbital inflammatory disease, there is a classification which all of you have to know. And it is actually classified as specific whenever you have a specific etiology where you can, relate this inflammation that is happening in the orbit. It is called specific orbital inflammatory disease, and the etiologies are varied. It can be granulomatous, it can be infective, it can be transitional lesions, vasculitic lesions, and many other and many more. So this patient was a case of vaginous granulomatous. So whenever there is a situation where you actually don't have an etiology which is diagnosed, then you call it as non-specific. So otherwise, it's also known as idiopathic orbital inflammatory disease. We no more call it an orbital pseudotumor, which was the historical name for the same. So basically, the definition for an idiopathic orbital inflammatory disease is it is when anything that is non-neoplastic, anything that is non-infectious, which is occupying a space in the orbit. So whenever there is the inflammation cannot be attributed to anything, then you call it as non-specific inflammation. The incidence is usually unilateral, but in children it can be bilateral. And classification, it can be diffuse or localized. And this is, I've put up this slide only for the students and the residents who are viewing this webinar today. So again, the localized can be further classified as anterior, posterior, dacryoadenitis, myositis, which affects the muscle. It can be atypical or it can be perineuritis. Now going on to certain cases. So this was an Asian child who came with a complaint of photophobia tearing. This was a main complaint. Okay, so the father brought the child. So when you look at her, you can see a lot of periocular swelling, more to photophobia and tearing. You can see that the periocular area has puffiness over the upper eyelid. And well, this was how when the torchlight was put into her eye, it was like excessively tearing. So now you have a case over here where you can see there is lots of hyperemia in the upper eyelid. She has tearing, photophobia, and whenever any patient, for of course, for that matter, who comes with the photophobia, the first thing that you look for is any corneal etiology or any uveitic etiology. So this was basically a case of anterior inflammatory orbital disease where the child presented with uveitis, tendinitis, and periocular, preseptal inflammation. So this is one of the presentation that you have to keep it in mind. She was treated with oral steroids because the parents were not willing to go for an intravenous steroid at that point of time. Considering the side effects associated considering and knowing the side effects associated with oral steroids in a child, it was started for her. Well, she did have a recurrence. So in these children, children presenting with inflammatory diseases in various forms can have bilateral presentation, as in this case, and also they can have recurrence. Well, after the oral steroids, then she was again started on IVMP, and well, she did well thereafter. This was a 30-year-old gentleman who presented with blurring of vision, and it was progressive. When he came to us, his vision was like 6/60 in the right eye. You can see that the pupil is slightly dilated over here. His color vision was also affected, and there was diplopia associated. So this was a case of actually a posterior apical neuritis where he had pain, and his there was a perineuritis associated with the myositis of the lateral rectus and some amount of posterior medial rectus involvement. So it can come as a combination if it is an apical orbital inflammatory disease where you absolutely have no clinical clue of inflammation in his eye. His only complaint was a reduction in vision and motility limitation with diplopia. So this was what inflammatory orbital disease can also present as. So all these things have to be kept in mind. This was a very, very interesting case. In fact, she has a long history as well. A 20-year-old student who presented with this severe swelling of the right eye and with acute onset of reduction in vision. And she was diagnosed as a case of orbital cellulitis, and she was started on antibiotics, but there was no resolution for the right eye. And well, when we look at the left eye, she does have inflammation and periocular swelling in the right as well, with enlargement of the palpebral portion of the lacrimal gland. And left eye was very, very bad. So as you can see here, there is complete total limitation of extraocular motility, severe chemosis. Her vision was affected. Her vision was 6/60. The reason for her vision getting affected was this large lesion, as you can see here, in the supraorbital area, and which was even compressing the globe over here and compressing the nerve. So she had enlargement of the lacrimal gland where the radiology really came handy over here. So she had an evidence of lacrimal gland enlargement in the right eye also. So whenever a case of orbital cellulitis presents to you with it is very, very mandatory to do a CT scan before you go ahead with the treatment. So CT scan revealed a bilateral dacryoadenitis and severe dacryoadenitis in the left eye. So dacryoadenitis, yes, it is presentation of orbital inflammatory disease, and 30 to 50% of the lacrimal inflammation have associated systemic disorder or simulating lesions, as is listed over here. So whenever you have a bilateral lacrimal gland disease, as you can see from this paper, which has been published, where idiopathic orbital inflammation comprises of 30%, well, it is also associated lymphoma and lymphoid hypoplasia equally. So this was how she was treated. She was started with oral systemic steroids, intravenous methylprednisolone. She did well in May. She was doing fine. August, well, she did look wonderful. But then she did have a recurrence again, and what we found was there was actually erosion, bony erosion, which has set in her orbit in the left side. So which was until now we have not done a biopsy. We were conservatively treating her, and this was how she we did a biopsy through the lid crease incision when we found that there was bony erosion in her case, and she came out to be a sclerosing variant of idiopathic orbital inflammatory disease with vasculitis. Her systemic evaluation was done. She was young. The C ANCA, the P ANCA, everything was ruled out, and there was no autoimmune disorders which was diagnosed at that point, and even IgG4 was ruled out. So idiopathic orbital inflammatory disease in a young patient or even in an adult can actually present with severe symptoms and signs. Bony erosion, whenever it's present, we are slightly worried whether it could be a malignancy or some infections like tuberculosis or fungal granuloma. But everything came out to be negative in her. We ruled it out. So this is yet another case of, who has been diagnosed as an orbital inflammatory disease. He has been having treatment for the past 1 year, steroids on and off, 34-year-old. But if you see the periocular area, it's not like an even swelling of the preseptal portion or the upper lid. You can see a slight, irregularity in the medial area over here. Although imaging was not done in his eye, he has been, always been on steroids treatment. So when you see the CT imaging over here, you can actually find a lesion which is in the superior and the supromedial orbit, where the muscles cannot be totally differentiated from the lesion. And this came out to be a case of non-Hodgkin's B-cell lymphoma. So such situation where, you have been treating the patient, and even at the first recurrence, it would be ideal to go ahead and do a biopsy and rule out, inflammatory and neoplastic disorders. So, and one thing that you have to always be careful is if at all the patient is on steroids, it is good to give, at least a window of 3 to 4 weeks in order before you go ahead with the biopsy. Yet another case, an endoscopic orbital biopsy was done in a right eye and by an ENT surgeon. So they just got vascular tissue and fat, and she has been having progressive loss of vision even after that, and it's associated with pain. And this is the right eye. So this is what we found, where there is involvement of the orbit, the medial rectus muscle, and also the paranasal sinus. So whenever there is an involvement of the paranasal sinus, the thing that really, the red sign would be a fungal granuloma or any infection. And that's what we thought as a differential diagnosis in her. And she also had myositis. So there are many other things that can actually affect the muscle, and all these are the differential diagnoses that you should be keeping in mind. Most of the time, these orbital inflammatory disease are not too direct for you. It has to be evaluated. So we again did an orbital approach, the limb approach, orbitotomy and incision biopsy. So this also came as a sclerosing variant of IOID. All right, so myositis is also common in inflammatory orbital disease. It can be one muscle or it can be multiple muscle of the orbit. So this was a 58-year-old lady who came with eyelid drooping. And well, she had a little bit of fullness in the periocular area in the right eye, as you can see here. And this was how her imaging looked like. The entire superior rectus LPS complex is enlarged, and she has been again on and off steroids, considering it as a myositis. But we went ahead doing a biopsy of the muscle from the conjunctival side, phoenicial and the conjunctival approach, and this also proved out to be a non-Hodgkin's lymphoma. So actually there can be a lot of twist entails in orbital inflammatory disease. You cannot consider it as very simple, straightforward. In such situation, biopsies has to be done. And this patient came with bilateral swelling of the lower eyelid, again thought to be an inflammation in an old lady. She was treated on steroids, but biopsy was mandatory. As you can see here, it was even involving the preseptal and the postseptal portion. And this came out to be a lethal malignancy, a small lymphocytic lymphoma or CLL in her case. My last case here, very interesting case, and this was a 48-year-old lady who came with kind of, on and off inflammation in the right eye. And this is all that she had. And she has this little bit of, edema in the caruncle. And she has history of recurrent sinusitis, nasal allergy. ENT has diagnosed as having septal thinning and DNS. And she's on treatment with steroids. She has a strong family history of cancer as well, father, mother, grandmother, and maternal aunt. But when we evaluated her and palpated, there was a small mass which was seen in the lacrimal sac area, but dacryocystitis was ruled out. Her syringing was perfectly fine, sac was good, and there was a mucosal polyp also in the sphenoid sinus of hers. So our working diagnosis was Wegener's fungal granuloma or even a benign tumor, but we definitely wanted to do a biopsy before going ahead with any other conservative management. Initially, it came out to be a Rosai-Dorfman disease. Immunohistochemistry was done, and Rosai-Dorfman disease, again, it's an inflammatory disease and histiocytic disease where steroids are given as treatment. But once we stopped the steroid in the first course, it again recurred back. So we reviewed with the ENT, and again a biopsy was done, and then this turned out to be a nasal natural killer T-cell lymphoma. So this is a very, very lethal lymphoma that this patient has. So the role of biopsy in orbital inflammatory disease, and that's exactly what I want to stress here today, is very, very important, because there are many things it can give you a huge twist in your diagnosis, and which sometimes can be very lethal to the patient's life. So clinical evaluation, a detailed evaluation, imaging, everything is very, very important in reaching to the diagnosis. And we always say that Orbit is a Pandora's box. Yes, Orbit definitely is a Pandora's box. So any inflammation, if at all there is a very slight suspicion, please do a biopsy and rule out any other twist in the story. Thank you so much.
Thank you, Fairuz. As you can see, she's an excellent speaker, illustrated very well all the situations of inflammation as well as the various malignancies which may present like inflammations and the role of biopsy. I think it has been stressed very beautifully in her talk. Thank you, Fairuz.
Thank you, sir.
And as you always say, you reserve the best for the last. In a mushaira, you always keep your star speaker for the end. So the person who's become a legend at a young age, Santosh Honavar, to cover this. And if we are overlapping a bit on the uveitis session, my apologies, but the subject is quite like uveitis again, so they would also enjoy this. Santosh. Unmute yourself, Santosh.
Am I audible now?
Yeah.
Okay. I'll be talking about some of the intraocular tumors and tumors causing inflammation. Tumors causing inflammation and, technical problems everywhere, I suppose, today.
Yeah, a delay because of the technical issues.
Okay. So this is a 47-year-old male patient who comes to us with a history of pain and photophobia in the left eye. He has had a history of conjunctival mass excision 4 times elsewhere in the past 2 years, but none of which have a histopathology evidence. He comes with conjunctival scarring in this area and some amount of congestion, and he seems to have a hazy vitreous. There is a D-shaped kind of deformity of the pupil here. Rest of the pupil is very spherical, whereas there is some straightening in this aspect. So on slit lamp evaluation, we found that he had flare and cells, and he had thickened ciliary body, which was kind of jutting out when he did look extremely and when we did an indentation. So that was the tip of the ciliary processes. On top of that, you find a lot of exudation there. So we went ahead and looked at the fundus on indentation. We found that there was a yellowish white lesion which was arising from the ciliary body, and there was a lot of exudation on top of it, and there was exudation in the vitreous cavity as well. On ultrasound, this is what we found. On B scan, we found a lesion which was in the ciliary body extending to peripheral choroid, and UBM, we found a ciliary body lesion. So this patient manifested with symptoms of uveitis, and we went ahead and investigated him. We found a ciliary body lesion with a lot of exudation. So finally, we had to enucleate him because of the worry that he may be harboring a malignant lesion, and he had no useful vision. And this is what we found on excision on enucleation, that he had a lesion in the ciliary body area, and that turned out to be a high-grade squamous cell carcinoma. So what had happened here was this tumor, which was lying outside the eye, had burrowed through the sclera and had gone intraocular. possibly because of multiple prior surgeries. You can actually see a nice track here in the sclera. So this patient, having had the tumor in the ciliary body, now manifested with uveitis. So intraocular extension of ocular surface tumors can manifest with uveitis. And this is one more example of an infiltrative mucoepidermoid carcinoma of the conjunctiva with hypopyon. This hypopyon tends to be white or pink or a mixed match of or a mixture of pink and white. So in patients where we have a suspicion that an extraocular lesion might have gone intraocular, we always have to do anterior segment imaging. The next group of diseases are where the large cells are present in the anterior chamber. Patients with iris melanoma, for example, can have large pigmented cells floating in the anterior chamber, which can be confused as uveitis. Sometimes you may not be able to see the tumor because it may be lying in the periphery in the angle. That's called a ring melanoma. And even melanocytoma can have pigment clumps in the anterior chamber. And it's easy to decipher why, because melanocytoma is a disc cohesive tumor and it releases pigment particles which settle in the eye on the iris. Suppose this melanocytoma were to be posterior, on the posterior aspect of the iris, then we won't even be able to see it unless we do imaging, and we'll have a lot of pigmented cells floating in the anterior chamber. Let's go on to tumors simulating granulomatous uveitis. Tapioca melanoma actually looks like granulomatous uveitis. If it's not very advanced, you'll simply find nodules like this on the iris, and that is an imaging which corroborates with what we see clinically. So this can mimic as granulomatous uveitis. In fact, metastasis also mimics granulomatous uveitis. This patient has had a bronchogenic carcinoma, known case of bronchogenic carcinoma, presents with what looks like uveitis, large nodules, but that was metastasis. Coming to the group of disorders with hypopyon. Even metastasis can cause hypopyon, especially GI malignancy. This patient had had a recent history of alternating constipation and diarrhea with bloody stools. And he came with what looked like uveitis. He had hypopyon and he had iris nodules, but that's because of metastasis. When a GI malignancy or adenocarcinoma metastasizes to uvea, it continues to maintain its primary activity of secretion, and these lesions tend to have secretory activity and hence this hypopyon. Next, if you have a patient with a white-eyed hypopyon, the patient does not have much of circumciliary congestion, but does have some amount of fibrin on the anterior lens capsule and has a white hypopyon. He is a 60-year-old male. Here you should suspect either lymphoma or leukemia. In fact, leukemia can manifest with a lot of other features such as large keratic precipitates. It can manifest with vitreous haze, as you see here, clumps of vitreous cells. All these are manifestations of AML, and of course, white-centered hemorrhages and soft X-rays and rod spots. So white-eye hypopyon is common in large cell lymphoma, leukemia. ALL is the most common variant to produce this kind of a manifestation, followed by AML and rarely CML. So all forms of leukemia can manifest with white-eyed hypopyon. But if you have a white-eyed hypopyon in a child like this, a 6-year-old child manifesting with white-eyed hypopyon, where our uveitis specialist had already done a fundus evaluation and found nothing, this was actually retinoblastoma lying in the periphery. So in such patients, unless we do examination under anesthesia, we may miss a small retinal tumor which may be lying in the periphery, extreme periphery in the ora serrata. So this is not typical hypopyon, but there are cells in the clumps of cells in the anterior chamber. This is again typical retinoblastoma. This is called migratory cells, kind of a anterior segment invasion, where tumor cells come through the zonules and settle down in the anterior chamber, whereas the infiltrative variant has contiguous extension through the ciliary body to the periphery of the anterior chamber angle and the iris, and can also have seeds like this. This can cause hypopyon. So either depository or infiltrative variant of anterior chamber extension or anterior segment extension in retinoblastoma can manifest with features of uveitis. This patient had to be enucleated, had a lot of seeds which were infiltrative. You can see that it is actually reaching up to the angle there, and he did have a large ciliary body extension. Now, RB can also manifest with uveitis, as you see here, and anterior segment cholesterolosis, which we generally see in Coats disease, can also happen in retinoblastoma. If you find a heaped up hypopyon like this, where there is no level and there are translucent sago granule kind of lesions within the hypopyon, then that is typical of medullary epithelioma. These are large balls of aggregates of tumor cells which look like sometimes retinoblastoma, but the tumor is very characteristic. It involves the ciliary body and can also have zonular coloboma. Juvenile xanthogranuloma typically produces streaks of hyphema, but can also manifest with uveitis. You can see keratic precipitates in this area with prior uveitis. Again, these patients tend to have a D-shaped pupil or a pupil which is distorted in the sector where the lesion may be present. And on systemic evaluation, you can't miss this very characteristic skin papules. So melanocytoma, melanoma, metastasis, lymphoma, leukemia, retinoblastoma, and medullary epithelioma can all have hypopyon and uveitis. Now, if a patient were to have hyphema and intraocular inflammation, then you must do imaging. This patient presented with severe inflammation of the anterior chamber first, and then over the last 4 or 5 days manifested with hyphema with some prior history of trauma and had a thickening of the iris. Whenever there is iris thickening, obviously it is not because of trauma, etc. This history may be very incidental. In this patient, steroids had already been started by the referral ophthalmologist. So peripheral blood smear and bone marrow biopsy when we did turned out to be negative, and only an iris biopsy could establish the diagnosis of AML. So AML can infiltrate the iris and can cause inflammation in the anterior chamber and can also have hypopyon, and the same patient after systemic treatment for AML and also EBRT for the eye. Some tumors cause retinal exudation, especially retinal hemangioblastoma can cause remote retinal exudation, which has this kind of a finger-like configuration, which is very, very typical. And these fingers point towards the fovea almost always. It goes away following cryotherapy. This particular peripheral lesion was cryoed following an atrophic scar, and the exudation promptly went away as well. One more reason why there could be retinal exudation could be vasoproliferative retinal tumor, retinal pigment epithelial adenoma, which arises from the precursor chirping, or adenocarcinoma of the retinal pigment epithelium, which can also have significant retinal exudation. In vitritis, if it presents with haze, cloud, or clump, then you must think of primary intraocular lymphoma. On closer evaluation, often you will be able to find retinal and sub-RPE infiltrates, which are very irregular and have variable pigmentation like this. And this can be simply treated with external beam radiation or intraocular injection of methotrexate or rituximab. In retinoblastoma, these are typical vitreous seeds, but sometimes vitreous seeds can present like a cloud. This can mimic actually vitritis, and these patients can be missed. In retinoblastoma, advanced retinoblastoma, inflammation is quite common. Retinoblastoma, especially when it undergoes necrosis, can manifest with inflammation, which can simulate orbital cellulitis. Even a benign tumor such as melanocytoma of the optic nerve, as you see here, can have necrosis and can cause inflammation. That was a melanocytoma which is going along the optic nerve. This patient was finally enucleated because he had neovascular glaucoma and was found to have melanocytoma going along the optic nerve, thus causing a combined CRAO and CRVO. Larger melanomas can also have necrosis and inflammation, and this was a ciliary body melanoma with necrosis and inflammation and hyphema, which following treatment with plaque brachytherapy resolved quite well. So in conclusion, I would say that ocular tumors can manifest with uveitis, so we always have to mind the mimic and recognize the real.
Thank you, Santosh. That was, as always, exceptional and educational. We learned a lot. Would like to, in the end, thank the team of KSOS, Dr. Sai, Dr. Gopal, and particularly Fairuz for organizing this beautiful educational activity. We'll hand over to Fairuz to say the last word. And again, apologize to the UVR session people for the delay due to the technical reasons. Fairuz.
Thank you, Dr. Grover, and thank to all the esteemed speakers for accepting our invitation and making this webinar very, very special. So although we kept the uveitis portion later, masquerading as uveitis, and I'm sure the uveitis team who has joined probably like this overlap as well, because there was a highlight of uveitis and inflammation and tumors as well. Thank you, Dr. Gopal. Once again, we're not taking your time anymore. Over to you. Thank you so much. Thanks,
Thank you
everyone.
very much, Fairuz. Yeah, thank you very much, Santosh. And big thanks to you, Dr. Grover, sir, for accepting our invitation and coming here. Lakshmi Madam, Shubhra Madam, all oculoplastic faculty, who's who of oculoplasty in India. Thank you very much. Now over to uveitis without moving into.
Thank you, Feroz. Thank you, everyone.
Thank you so much. Hi, Natasha. I can see you there.
Yeah, so without wasting any more time, let us move into uveitis. Let me introduce the course director, who is none other than the great Dr. Jyotirmay Bishwa. Sir, the stage is set for you to take it up, and then moderators would be Rima Bensal, Natasha, and our own treasurer of the Kerala Society of Ophthalmic Surgeons, Sebastian. We have star-studded a team of uveitis as well, with Dr. Anuradha VK, my classmate. She will be looking at overview of uveitis and evaluation of the patient, including history. And then Dr. Partha will be looking at anterior uveitis. Dr. Rima will be looking at posterior uveitis. Pediatric uveitis will be taken care by Dr. Natasha. And final word in uveitis, pearls in uveitis, and also in pan uveitis will be by Dr. Jyotirmay Bishwa. So over to you, sir. You can unmute yourself. Okay.
Good afternoon or good evening. Today I like to start with that uveitis session. I think it would be quite interesting and useful. Let us find out who are the people joined. Partho has joined.
Yes, sir. All of us have joined, sir. All the uveitis faculty has joined. Yeah.
Okay, all the uveitis faculty has joined. Uveitis, that is one of the really is a challenging disease and little less covered, but it can cause a loss of vision in our visual morbidity. In about 25% of the cases, even legal blindness can occur. It can be really challenging. It's not only the steroids and all the diagnosis of the TB uveitis. There are so much variants of uveitis are there. Without much ado, I will ask Dr. Anuradha from Aurobindo Eye Hospital, Coimbatore, to tell that history taking a examination of uveitis, the preliminary part of the uveitis. How do you approach a case of uveitis? Dr. Anuradha is from Aurobindo Eye Hospital, Coimbatore. Over to Anuradha.
Thank you, sir. I hope all of you can hear me.
Yes.
Yeah.
Yes.
Good evening to all. Let's share the screen.
Yeah, you can share your screen, Anuradha.
Yeah, share the screen.
Where is it? This one. Okay, here we go.
Just click on it.
Yeah.
Yes.
So yes, you can see the slides, right?
Yes.
Yes. So it's a pleasure to be part of this meeting as always, and I wish to thank the organizers of Ophthalmology Reboot and Gopal in particular for inviting me to be part of it. Topic is a clinical approach to uveitis. So my way of looking at this, uveitic diagnosis, I feel it's like putting together pieces of puzzle, pieces which consist of the patient demographics, the ocular history, the medical history, the clinical findings, investigations and response to treatment. And depending on how well you put together these pieces, you get a clear picture, hopefully towards the end. And do this by asking ourselves and the patient a series of questions. The first of which is, who is my patient? Second is, where is the maximum inflammation? A third is whether it's a granulomatous or a non-granulomatous uveitis. Fourth is whether we are looking at an infectious process, an autoimmune process, or a masquerade. and whether we need to do investigations, if so, what, when, and how. So probably there's no other subspecialty in ophthalmology which relies so much on history in making a diagnosis as uveitis. So in other subspecialties, you might just get away with, not just knowing the age and the sex of the patient. But in uveitis, it's very important to go into details like occupation, family history, social history, and medical history. And I'm just, going to go a little bit more into detail here. For example, the age of the patient is important because something like a JIA uveitis is more common. It's more in the pediatric age group. Whereas the young adults, they tend to get seronegative spondyloarthropathy. And going by the same example, the GI uveitis is more common in the female population and the seronegative spondyloarthropathy in the male population. Now, what the patient does for a living, also might have implications. For example, those who work on agricultural land, they might be prone to diseases like leptospirosis. And we all know that, we as medical professionals, we are exposed to diseases like tuberculosis. It's also very important to inquire after the health of the family members. I wish to share a story actually. A few years ago, I had a young girl who came with bilateral panuveitis after a history of chickenpox a few weeks ago. And she was accompanied by her maternal grandfather. So at that time, I was just concentrating on the eye. So I started her on antiviral and then, wrote for a few tests. She comes back after 3 days with the test reports, again accompanied by the maternal grandfather. And this time I ask about her parents. And he says the mother has gone to work and the father is no more. And he also very casually slipped that he was no good. He was of bad character. So something clicked in my mind because she was actually undernourished, small for her age. And I tested her for HIV and she was positive. So paying attention to subtle clues, can go a long way in helping you with your diagnosis. Also, what they eat and drink might be important in diseases like toxoplasma and cysticercosis. And their systemic illness and the interventions they have undergone and the medicines they take may also provide you with clue to the diagnosis. The second thing is the ocular history itself. And depending on whether it's a single episode or multiple episode, we actually classify into acute, recurrent, and chronic. The difference between the recurrent and the chronic is that in recurrent, you have a gap of more than 3 months of no inflammation after discontinuing treatment. But if the inflammation recurs within 3 months of discontinuing, or sometimes you cannot even taper them off the treatment, you call it a chronic uveitis. It's important to know this because certain uveitis follow certain patterns. For example, classically, the HLA-B27 uveitis and viral tend to be recurrent, whereas TB and Hansen's, can have very chronic inflammation. So to illustrate this, these are two cases of hypopyon uveitis. If you look at it, there's a lot of possibilities. It could be infectious, it could be non-infectious, it could be a masquerade. But if I tell you the first eye belongs to a 28-year-old male who has been having recurrent inflammation alternating between two eyes, has a low back pain, which happens first in the morning and it's relieved on, getting up and moving around, you're looking at a non-infectious process and probably a seronegative spondyloarthropathy. If on the other hand, this hypopyon uveitis, which has happened in a relatively quiet eye, it belongs to a middle-aged patient who's complaining of a lot of tiredness, bone pain, and bleeding gums. You need to worry about a masquerade. So even without doing tests, you already have arrived at the most probable diagnosis here. The second point is where is the maximum inflammation, and depending on that, you classify it into anterior, intermediate, posterior, and prime uveitis. In anterior uveitis, the inflammation is maximum in the anterior chamber with, you might have a few AVF cells, but no significant haze. Sometimes you might have a cystoid macular edema that is allowed. In intermediate uveitis, the inflammation is maximum in the vitreous and the pars plana region. Again, you might have cystoid macular edema very commonly associated with, or you can have peripheral vascular sheathing, but no focal lesions in the fundus. In posterior uveitis, you have focal lesions like retinitis, choroiditis, vasculitis, or exudative RD. Now, in both intermediate uveitis and posterior uveitis, there's no or very little inflammation in the anterior chamber. Now, there are situations where you get significant inflammation in the vitreous as well as in the anterior chamber with no focal lesion. You call that anterior with intermediate uveitis. But if the same thing happens with the posterior uveitis, as you have posterior uveitis plus significant inflammation in the anterior chamber, you call it a panuveitis. Once again, this classification is important for two reasons. One is certain diseases have certain site preferences. For example, J.I.N. Hansen is anterior uveitis. Toxoplasma could be a posterior uveitis or a panuveitis usually. ARN is usually a panuveitis. Our next question is whether it's a granulomatous process or not. Two important clues. One is the keratic precipitates. You all know that in granulomatous inflammation, you get these large keratic precipitates, and when they are yellow and greasy, you call it mutton fat keratic precipitates. Whereas when you get these diffuse stellate KPs on the endothelium, it suggests fuchs or fuchs-like uveitis. The other clue is the presence of iris nodules. The copace nodules, which are located on the pupillary margin, they are non-specific. They can happen in both non-granulomatous and granulomatous inflammation. Whereas these sago pearl-like nodules within the iris stroma or in the angle suggest a granulomatous process. The reason why you want to identify disease as a potentially granulomatous is that it automatically cuts down your list of possible suspects. So, you might be able to come to a definite diagnosis. The common findings in fundus and posterior panuveitis is choroiditis or retinitis. And sometimes it's difficult to differentiate the two. I just want to tell the clinical points here. Actually, in many cases, just by looking, you'll be able to differentiate it. So choroiditis, tend to have more defined margins as compared to the retinitis. The retinitis margin is more like a cotton wool spot. The color is also more yellow in choroiditis, whereas it's more of more whitish in retinitis. And you can very clearly see that the retinal blood vessel is over the lesion in choroiditis, whereas here the vessel actually runs through the lesion. And retinitis also tends to have more of vasculitis and hemorrhages as compared to choroiditis. The other lesions you may see is vasculitis and exudative RD. And in vasculitis, it's also very important. You can have a combination of lesions. It's not that they all appear in isolation. Particularly when you have vasculitis, it's very important that you look for a focal lesion like a choroiditis or retinitis. Exudative RD, probably the most common cause we see is VKH, followed by symptomatic ophthalmia. But it's also very important to rule out masquerades and CSCR. Coming to the next question, whether it's an infectious, autoimmune, or a masquerade, I think we have actually listened to a wonderful talk on that already. But these are my points, for suspecting an infectious process or a masquerade. One is extremes of age, very young or very old patients, then I would think of a masquerade or an infection. Any inflammation in an immunocompromised patient, whether it's an HIV patient or a iatrogenically immunocompromised patient, I would consider it an infectious process until otherwise proved. Similarly, de novo inflammation after a recent systemic illness, hospitalization, IV fluid, or a trauma surgery to the eye, I will look at it with suspicion. When it comes to the top findings, which makes me think of infection or masquerade, it's hypopyon, has already been elaborated on. The other point is retinitis tends to be usually infectious, in our day-to-day practice. By and large, non-infectious causes of retinitis is a bit uncommon. And the final point is any atypical presentation as well as a poor response to steroids should make you think of an infection or a masquerade. I'm not going to go into details of the investigations, except that, the investigation should be guided by the clinical findings. You should be aware of the sensitivity and specificity of the test you're ordering, and you should order the least invasive test first. And hopefully, by putting together all of it, you will come to a diagnosis, or at least a working diagnosis in most patients. Thank you.
Dr. JB sir, you can unmute yourself.
Thank you, Dr. Anuradha. Very excellent disposition of a practical approach to uveitis history taking, as well as the examination and investigational approach. The history is one of the important point of the history is that whether the patient is immunocompetent or immunodeficient. That will make a lot of difference, because the immunodeficient patients might have infections, very unusual infections like viral, tuberculosis, etc. Or whether the immunocompetent patients might have, most of the times, is that autoimmune uveitis or infectious uveitis. The investigational approach, in examinations, we should do the indirect ophthalmoscopy. Even there is an anterior uveitis is present, we look for carefully the pars plana region to the vitreous exudates. In the slit lamp also, you look for the vitreous cells in the one and in the anterior chamber examinations, and that will help us to find out whether there is a intermediate uveitis or not. And so this has been very elegantly covered. I think we should take up the questions at the end. Now I have got the very pleasure and very much pleasure and privilege to welcome Dr. Parthapratim Datta Mojumdar, who is from Shankar Nethralaya, UVA department, my colleague. He will be talking on a very important and very commonly seen uveitis that's called anterior uveitis. Almost 40 to 50% of our uveitis chunk is anterior uveitis. So over to Partho. Partho will give a bird's eye view of anterior uveitis. Partho, please.
Thanks, sir. Can you hear me, sir?
Yes.
Am I audible?
Yes.
Yeah. So first of all, thanks to Dr. Gopal Pillai and the team COC, the Cochin Ophthalmic Club, for giving me this opportunity. So I'll be talking on anterior uveitis. And because the time is 10, so I have decided to go with 10 pearls in 10 minutes for uveitis. For audience, I'll be available in this email ID also. So in case, because of the time constraint, you can't ask any question, I'll be happy to answer your query if you mail me your question. Now, starting with the first part, that history taking. As Dr. Anuradha already mentioned, I want to start this topic with a brilliant quote by William Osler that, listen to your patient, he is telling you the diagnosis. So this is very important in uveitis. Like, I'll give you an example. A patient of hypopian uveitis has come to you. There is no history of surgical intervention. So there can be many differential diagnoses, like HLA. It can be due to HLA-B27. It can be due to Behçet disease. It can be due to endogenous endophthalmitis. But if you take the history, then you can easily summarize them like this way. So if a patient with anterior uveitis with hypopian gives you a history of backache, recurrent attacks alternating between the eyes, then you have to suspect HLA-B27. If there is a history of genital ulcer, frequent painful oral ulcer, then you can suspect Behçet disease. Similarly, the history of diabetes mellitus, history of hospitalization, intravenous therapy can lead you to the diagnosis of an endogenous endophthalmitis. So my next second point is, there is a proverb, if you know, remember, that the unlucky doctor treats the head of the disease and the lucky doctor its tail. So you have to understand that you have to clinch the diagnosis by examining from head to tail. So this is very important. So how we can do this? We have to understand the extent of a particular anterior uveitis or inflammation. For example, a patient presented with anterior uveitis, then we have to go and examine the eye properly so that we can understand what are the other ocular manifestations he is developing. Next is to go beyond that and examine the system. So this is very interesting. I'll give you an example for this. For example, a patient has presented with bilateral granulomatous uveitis. Now, if you start treating this patient only with topical steroid, you may miss so many things. So you have to examine the patient properly, and maybe you can come across vitreitis, exudative retinal detachment. Then you realize that you are dealing with the panuveitis. Then you start examining the system, the periphery, take a history. Again, you examine the patient, and the patient may give you a history of alopecia, vitiligo, tinnitus, and meningismus. So this is very important. When next time you see a patient of anterior uveitis in your clinic, you have to understand the extent of the anterior uveitis. My third point is keratic precipitates. It's very important to examine and observe that whether there is any keratic precipitate present or not. If the keratic precipitate is present, then you have to see what kind of keratic precipitates they are. Look at the morphology, whether they are mutton fit capes, they are small, fine capes, or they are steelhead shaped. So this can help you to diagnose the subtype of the anterior uveitis. The next important point in keratic precipitate is the area of distribution. If you consider it as a midline, you have to see that what are the whether the capes are crossing the midline or not. So you have to remember 2 points, 2 clinical entities that can cross the midline. One is Fuchs uveitis and another is viral uveitis. The second point is, fourth point is the examine before the dilatation. Now, many a time what happens, we don't examine the patient before dilatation. Even in a tertiary center, first optometrists see a patient, they dilate the patient, and sometimes the patient come to your OPD. So this is very important to examine a patient before dilatation. So sometimes you can miss the iris nodules. Like in this case, if you dilate the patient, you may miss this iris nodules, and the finer details of the iris like crypts and this collarete, the finer, smoother appearance of this iris structure you can miss when the iris is dilated. So that's what it's very important to examine the patient after dilatation, and you must dilate a case of anterior uveitis and examine the periphery. I'll give you an example of 43-year-old lady who presented with mild ocular pain, who was started on treatment with topical and extensively investigated. When I dilated the patient, the fundus looked like this. So 2 things we learned from here. One is fundus examination is must in all cases of anterior uveitis, and the second is you have to meticulously examine the periphery. Like peripheral lesions can be missed if not thoroughly examined. Like in this patient, the patient was having acute retinal necrosis, which starts from the periphery. If you don't examine the periphery properly, you may miss the acute retinal necrosis. Now the number 6 is the iris details. You have to always rely on the iris details, not the color, for diagnosing Fuchs uveitis. Now the Fuchs uveitis is one of the most underdiagnosed and most over-treated uveitis. Many a time we suspect some other clinical entity and treat them with oral steroid or oral steroid. So you have to diagnose it, and mainly it happens because of the standard teaching which says that the Fuchs uveitis is a heterochromic iridocyclitis. But what happens, like heterochromia, we believe that heterochromia is a universal feature in Fuchs uveitis. But the fact is, heterochromia is often subtle or absent, especially in people with darker eyelids. Like in Indian population, it can be very subtle. So one must rely on other signs of the Fuchs uveitis. What are these? Like if you see the fine and stellate appearance of the KP, if you see a diffuse distribution, if you see the moth-eaten appearance of the iris, and if you see the blurring of the iris crypts, spatially in the collarete, which gives the iris surfaces a smooth velvety appearance. So these are the features that should prompt you to diagnose a case of Fuchs uveitis. Now the 7th point is the children with anterior uveitis. So any children presenting with anterior uveitis, you need to rule out juvenile idiopathic arthritis. Now there are few certain features you have to remember. One is the white eye. Most of these children, they don't develop any congestion and they present with white eye. The number 2 important point is they run a chronic course. So you have to be aware of that and take repeated history. You have to examine the patient at regular interval. The third point I want to highlight is the band keratopathy. So band keratopathy usually denotes the prolonged intraocular inflammation. So if you see a children with white uveitis, with a chronic course and with band-shaped keratopathy, especially the girl child, you have to rule out JIA. Do send this patient to a pediatric rheumatologist or a rheumatologist. Now, the eighth point is that sometimes we see the uveitis after surgery, which can be due to any patients with a history of uveitis. After surgery can develop intense inflammation. Next is we have to rule out the post-operative infection or the low-grade endophthalmitis. Retained lens matter sometimes can cause uveitis, so you have to pick up from the history also and meticulously examine this patient. And the fourth one is very important, that sometimes, especially in the hands of beginner, the 3-piece IOL, if placed in sulcus, can cause a lot of reaction and rise of intraocular pressure and uveitis. So you need to rule out these entities. Now, coming to the 9th point, there are a lot of topical steroid available in the market, but we often see people are using dexamethasone, we are using betamethasone. So you have to remember two things. The corneal stroma is hydrophilic and the epithelium is lipophilic. And there is something called moieties, which this moieties I have highlighted in black. So this moieties is like a boat. They transfer the molecule from here to the inside the anterior chamber. So this is very important to understand that the acetate has both lipophilic and hydrophilic moieties, whereas the phosphate has only hydrophilic moieties. So that's why the prednisolone acetate, which is 6 times less potent on molar basis than the dexamethasone and betamethasone, has highest absorption when we compare them. So always you have to use prednisolone acetate in a case of anterior uveitis. The same point, I just want to continue that you can use any cycloplegic depending on the severity of the inflammation, but better to avoid cyclopentolate because it has been found to have chemoattractant properties. Now, coming to my last point, you have to understand the systemic medications in anterior uveitis. There are certain indications that you need to understand. These red spikes are representing the inflammation. So you have to from history and examining, you have to understand that what is the duration of the recurrence. For example, a patient with HLA-B27, if the duration of recurrence is less than 3 months, then this is the time you have to start an immune suppressive agent. Whereas a HLA-B27 patients is getting recurrence once in a year, you may it's not required to start the methotrexate. So the duration between the recurrence is very important. Now, second point, which I want to highlight is the chronic smoldering inflammation. So this is equally dangerous. For example, a person is having a high-grade acute anterior uveitis, then running a chronic smoldering course like this. So this is equally dangerous than the recurrent attacks. This second variety, this variety can be seen in patients with juvenile idiopathic arthritis. They are known to run a chronic smoldering course. So in such scenario also, you need an immune suppressive to reduce the side of the systemic topical side effects and may bring the curve down. So make the curve flatter. I hope I could cover the highlights of the anterior uveitis in this presentation. Thank you for your present listen.
Thank you, Partho, for a wonderful presentation, 10 tips which you have given. I just wanted to highlight one point, that a granulomatous uveitis at the beginning can be a non-granulomatous one. But non-granulomatous uveitis like HLA-B27 very rarely present with mutton fat KPs. So you don't rule out when you see a non-granulomatous uveitis like TB or sarcoid for that reason. Another point which I highly appreciate, you have told about that intermediate uveitis doing the rule out acute retinal necrosis. All the patients of anterior uveitis at the first opportunity, whenever the possible, you should see the fundus, particularly rule out the intermediate uveitis like pars planitis or acute retinal necrosis. This is quite common. And I have seen a patient who had presented with the anterior uveitis, mutton fat KPs and all. And then I was treating as a tubercular uveitis. But when you look at the fundus, I found there is a posterior uveitis and the patient had toxoplasmic retinochoroiditis. In the treatment part of it, you have told rightly that mediatics like cyclopentolate should be avoided. At the beginning, we can give that homatropin eye drops, but if it's a fibrinous anterior uveitis, I often feel that ectropion is better. So these are the practical pulse which you have rightly has given and will be very valuable for the postgraduates. I now have got the privilege and honor to invite a very brilliant ophthalmologist, uveitis expert, Dr. Reema Bansal, who is from PGI Chandigarh, Postgraduate Institute of Medical Education and Research, Chandigarh, where also I have been got my residency, and she would be talking on posterior uveitis. She has got excellent, she has great experience of seeing the posterior segment of the eye. She also deals with the vitreoretinal diseases and vitreoretinal surgery. So she would be giving an overview of posterior uveitis. So 10 minutes we'll look for the posterior uveitis. Dr. Reema, please.
Thank you, sir. Can you hear me?
Yes.
So thank you very much, Dr. Gopal and the Kochi Ophthalmic Society for this wonderful opportunity. And from whatever inputs I've seen on the WhatsApp group and from all over, I think you've done a great job. So much of all specialties covered so well. So hats off to you, Gopal. So my topic is on posterior uveitis. So when we talk of posterior uveitis, the first thing that we need to differentiate or that comes to our mind is whether we're dealing with an infectious or a non-infectious etiology. So when you think of infectious, you have various causes like tuberculosis, viral, toxoplasmosis, fungal, Lyme's disease, Bartonella, and you can go on and on. In non-infectious, the commonest is VKH disease, sarcoidosis, Behçet's disease, sympathetic ophthalmia, and the various white dot syndromes. Now, before we go on to find the etiology, whether it's infectious or non-infectious, it's most important to differentiate what kind of lesion that you're seeing. So if you have a differential diagnosis of posterior uveitis in your mind, I think you're on the right track. For example, many times we see some lesions where you are not very sure of what you're dealing with. And this is what our fellows usually ask the basic question, are we dealing with a choroiditis or a retinitis? So we have these two different patients. The one on the left presents with decreased vision, sudden onset, only counting fingers vision. And the one on the right presents again with decreased vision, but 6/12 vision. Now, if you look at the difference between the lesions of the two, you have similarities as you have two similar kind of lesions, solitary in the posterior pole, causing acute loss of vision. But the difference is, if you look at the lesion on the left, the lesion is much deeper. There's a lot of exudation around the lesion in the form of subretinal fluid, and there's some kind of vascularization of the lesion if you look carefully. The one on the right is a fuzzy lesion. It's not so deep as the one on the left. It's crossing the retinal vessels. It's hiding the retinal vessels partly. And when you do the ancillary imaging, first of all, the OCT, which I think is the most important in this, you see on the left, the RPE is showing a huge bump. That means it's involving the choroid. There is subretinal involvement, of course, because of the exudation. And the one on the right shows, the OCT shows it's a flat retinochoroid complex. And whatever you're seeing is on the neurosensory retina. So you have the retinal layers involved on the right side, and on the left side, you have something coming up from the choroid. Now, if you do the fluorescein, the case on the left is on the top, and the case on the right is on the bottom. If you see the fluorescein, you have a hypolesion in the early phase, followed by hyperfluorescence in the late phase with diet pooling, which is suggestive of a choroidal lesion. On the other hand, the one on the bottom that you see, you start with an early hyperfluorescence in the angiogram, and which increases in the late phase. So this is, you're dealing with a retinitis versus a choroiditis or a choroidal lesion. Similarly, their healing pattern is also very different. Once you start treating them, this is what you have. Choroidal granuloma would heal with significant scarring, whereas a toxoplasmic retinochoroiditis, where predominantly it is the retina which is involved with secondary involvement of the choroid, you have minimal scarring if you treat the patient on time. So again, if you see a different kind of manifestation, a different phenotype of posterior uveitis, and which is very common, is retinal vasculitis. Again, you think of infectious versus non-infectious. When you think of infectious, you have various causes like TB, toxo, viral, syphilis, and non-infectious, sarcoidosis, Behçet's, collagen vascular diseases, multiple sclerosis, and IRVAN. Now, what's important in retinal vasculitis is pattern recognition. That means you need to see what kind of vessels are involved. For example, whether it's the large vessels, the medium vessels, the small vessels, or the capillaries, whether it's occlusive or non-occlusive vasculitis, whether the vasculitis is focal or diffuse, or the vasculitis is just on the posterior pole, or it's involving the mid-periphery or the periphery as such, or if you have any associated lesion along with vasculitis, whether in the fundus or in the anterior segment, accompanied with some kind of inflammation. And of course, you see the other eye for any clues of healed uveitis in the same eye or in the fellow eye. When you think of vasculitis, it could be predominantly involving the arteries. When we call it primarily a retinal arteritis, you need to know whether you're dealing with a primarily retinal phlebitis or involvement of the veins, or you have both. So if you have arteritis, you're dealing with mostly collagen vascular diseases, syphilis, toxo, viral, IRVAN, or Suzak syndrome. When it's primarily the venous involvement, you have sarcoidosis, multiple sclerosis, pars planitis, and so on. And when both you think of TB as the first possibility, followed by lesser common causes like relapsing polychondritis and GPA. Again, the other clues, as I said before, that you need to see with vasculitis, which would give a clue to the etiology, whether you have some kind of retinitis along with vasculitis. If yes, you're dealing with probably toxoplasmosis, viral, Behçet's or SLE, or if you have choroiditis with vasculitis, which points to TB and sarcoid. Again, whether you have cystoid macular edema, if you have, it's TB, sarcoid, or vascular inflammations, or whether you're dealing with a vasculitis which doesn't have CME. Generally, first thing that comes to your mind is an intraocular lymphoma. Toxo, it's uncommon to have CME. Herpetic usually do not have CME, and Behçet's may present with or without CME. So look at this case of bilateral vasculitis. This was a young male who presented with sudden onset bilateral dimness of vision. You can see completely knocked out retina with so much of infarction, cotton wool spots, hardly any blood supply. And what's most important is to do a fluorescein angiography in this. And with what we found, there was complete knockdown of the circulation in both the eyes, more in the left than the right eye. So retinal vasculitis is usually identified on the basis of the presence of perivascular infiltrates, leakage of dye on fluorescein angiography, which is a must for the diagnosis and categorization of retinal vasculitis, and to look for any evidence of intraocular inflammation without another cause of retinal vascular disease. And keep in mind that the vast majority of the patients with retinal vasculitis do not really have systemic vasculitis. So let's see what kind of vasculitis we see in tuberculosis. It could be like perivascular cuffing involving all the quadrants, as you see on the left. It could be with optic disc edema, as you see on the right, and along with perivascular choroiditis scars, which are usually healed, which may be active also. The fluorescein shows some kind of capillary non-perfusion or ischemic sequelae like neovascularization. It can present also as inflammatory BRVO with cystoid macular edema, or sometimes the patient, you have a young male patient presenting with just vitreous hemorrhage without any clues. So once you clear this vitreous hemorrhage, do a fluorescein, you realize that you're dealing with tubercular retinal vasculitis. Or it can be presenting with a large choroidal granuloma, which is a rare representation. Coming to the choroidal granuloma in TB, as I showed you before, it's usually a subretinal lesion, solitary and posterior pole, accompanied with massive exudative retinal detachment. It has a mass-like lesion with significant volume, and there is significant vascularization of this lesion. The other manifestation of TB posterior uveitis is serpiginous-like choroiditis, which could be in the form of multifocal lesions or a placoid lesion. Toxoplasmosis is another infective cause of posterior uveitis. You have a very classical lesion of retinitis or retinochoroiditis, which is the commoner presentation. A lesser commoner presentation can be like this, where you have a subtle involvement of the fovea, and which is more prominent on the fluorescein angiography. You need to look for these scars in the fellow eye or in the same eye in the periphery. Viral posterior uveitis, of course, comes with a lot of media haze and these tongue-shaped lesions of retinitis. Or CMV retinitis, which is with clear media, the vitreous is relatively clear, and you have this kind of brush fire appearance. Fungal posterior uveitis, if presents in the early stage, can present as a retinitis, usually at the posterior pole, and the OCT demonstrates beautifully the invasion of the retina from the choroid, or it can present as a full-blown endogenous endophthalmitis with hypopyon. Sarcoidosis presents as periphlebitis with typical segmental cuffing and perivenous infiltrates with Canthal strippings and commonly associated with cystoid macular edema. The choroidal lesions are either in the form of multifocal nemular lesions in the periphery, or they could be like this, involving the stroma in the posterior pole. They're much deeper. Optic nerve involvement is mostly in favor of sarcoidosis. If you see this kind of patient with uveitis, first differential diagnosis is sarcoidosis. Behçet's disease is more of a panuveitis, where the anterior uveitis is almost always non-granulomatous and frequently is accompanied by diffuse vitritis, retinal infiltrates, predominantly involving the retinal veins, and the vasculitis is occlusive nature. You may have a frosted branch gingivitis in Behçet's disease. Of course, you need to look for systemic manifestations like oral ulcers or skin or joint involvement. The hypopyon in Behçet's disease is mostly a cold hypopyon. That means there is no congestion, and as you see on the left, and it could be a shifting hypopyon as you see on the right. Weak edge disease is another common manifestation of posterior uveitis. You have these multiple pockets of serous retinal detachment, diagnosed and confirmed on fluorescein angiography, and the best modality for diagnosis and monitoring response to therapy is the OCT, EDI OCT, where it showed suprachoroidal thickening, subretinal fluid, and subretinal fibrin. In the late stage, it can present as sunset glow fundus with multiple posterior synecdoche, showing the chronic recurrent nature of the disease. You can have these nemular chorioretinal scars in the late phase with sunset glow fundus. Always need to look for poliosis or vitiligo in such patients. So winding up with posterior uveitis, when you see these kind of clues, and keep in mind, if you see retinitis versus choroiditis and you're sure you're dealing with retinitis, most often it's an infectious process. So when you think of infectious, you have a list of differentials in your posterior uveitis. And when you think of non-infectious, this is what you're dealing with. So thank you very much.
Thank you, Rima, for elegant presentation of posterior uveitis. You have given a bird's eye view of posterior uveitis. I just wanted to tell you that one important point which you should not miss, like the intraocular lymphoma, where they present as a choroidal lesions, and there you can see that like a small white spots, that leopard skin-like appearance. Or a patient can present with a vitritis in elderly people, particularly in the over 50, and is not responding to the steroid. In such cases, you should go for a vitreous biopsy at the first one. So another important point is that probably that Behçet's SLE is the conditions where you don't treat with the steroid alone. We need to go for immunosuppressive agents. Is very important. That saves the vision of the patient. Viral retinitis is one of the things which is a quite emergency in our setup, particularly acute retinal necrosis. We need to diagnose as soon as possible and treat with the antiviral agents as soon as possible in the high dosage like intravenous or intravitreal. That's quite important. Now I've got the privilege and welcoming Dr. Natasha Radhakrishnan, who is from the Amrita Eye Institute, Amrita Medical Institute, Institute of Medical Sciences, Cochin. She is from Cochin itself, and she would be giving an overview of pediatric uveitis. So over to Dr. Natasha.
Good evening, everyone. Am I audible?
Yes.
Thank you, sir. for giving me a chance to be in this session. Although I am like host faculty, I must say a hats off to the organizers for pulling off this wonderful session. Let me go into the topic, pediatric uveitis. Childhood uveitis is not as common as adult uveitis. In the age group 0 to 4 years, the incidence is around 3 in 1 lakh. 10 to 14 years, it's about 6 in 1 lakh. The most common is idiopathic, and it's often a chronic anterior uveitis, though in 8 to 16 years age group, it can be the most common is intermediate uveitis. By age group, if you see in the 0 to 6 years, it's a chronic anterior uveitis of juvenile idiopathic arthritis that is most common. Though in older children, it is idiopathic, and it may be chronic anterior or intermediate. And from 13 to 16 years, you will see the B27 associated anterior uveitis as well. We follow the same classification for pediatric uveitis: anterior, intermediate, posterior, and pan, and acute, chronic, and recurrent, and divided into granulomatous and non-granulomatous. Of course, I need not go into the features of anterior uveitis: the keratic precipitates, the festooned pupil, the posterior subcapsular cataract, pigments on anterior lens capsule, the band-shaped keratopathy. And often, this is a list of causes in children. Like I said before, JIA, juvenile spondyloarthropathies, can be viral uveitis, sarcoid, Behçet's, and intermediate uveitis can be just idiopathic pars planitis, sarcoidosis, chronic cyclitis, Behçet's syndrome, Lyme disease, multiple sclerosis. And posterior uveitis, again, infective and non-infective, which has been covered earlier. Toxoplasmosis can be seen in children, presenting with the headlight and the fog appearance. Tuberculosis also can be seen in children either as tubercles or granulomas or tubercular abscess. Sometimes the cause can be extremely rare, like in this child, 8-year-old boy, history of decreased vision in the right eye for 2 months. There was no history of any other systemic symptoms. Presented with 2/60 with an early band-shaped keratopathy and festooned pupil, but the lens was completely cataractous. So we did ultrasound, showed only a few cores, vitreous echoes with no retinal detachment or tumors, and basic infective workup also came up negative. So the patient was planned for cataract surgery under immunosuppression. Post-operatively, in the extreme periphery, in the supratemporal periphery, there was a granuloma-like lesion. So a clinical diagnosis of toxocara granuloma was made, and patient was put on albendazole, and post-operatively visual acuity was 624. However, on stopping the treatment, came back with severe inflammation and retinal detachment. This time, we went in for surgery and took a histopathology from the granuloma. The retinal detachment was settled with endolaser and oil, and the granuloma was confirmative of a toxocara granuloma. They can also have vasculitis, arterial or periphlebitis or combined vasculitis, and we already dealt with the masquerade syndromes that may be seen in children. Now coming to the most common systemic association of anterior uveitis, which is juvenile idiopathic arthritis in children. The risk factors: female usually, oligoarticular when they have less than a few number of joints involved, younger age group, ANA positivity, and they are rheumatoid factor negative. They are usually bilateral and non-granulomatous. Because they are completely asymptomatic, they often come to us with complications like band-shaped keratopathy, posterior subcapsular cataract, extensive posterior synechiae, secondary glaucoma, macular edema, and often these children are amblyopic as well. And it is this asymptomatic part of it that makes this disease so vision-threatening. Usually, it is an anterior uveitis. It's a white eye. Complications, like I said, are common, and it often leads to hypotony in the late phase. We should remember in the treatment of JIA uveitis that topical medications have a very adjunctive role. And if you need more than 3 drops, steroid drops, for more than 3 months, you should be considering systemic immunosuppression for these children. And it should not be just systemic steroids. They do require systemic immunosuppression with slow tapering of the steroids. And screening is mandatory of all children who are having JIA, as well as all children who come to you with an asymptomatic white eye should be sent for a JIA screening to the rheumatologist. The juvenile spondyloarthropathies, they include juvenile ankylosing spondylitis, Reiter's, psoriatic arthritis, and the GI diseases, ulcerative colitis and Crohn's disease, and they constitute 15% of pediatric uveitis. Often affected are boys more than 8 years of age, acute recurrent uveitis, and they can present with a severe acute anterior uveitis and hypopion. Inflammatory bowel disease again can present with acute anterior uveitis and episcleritis. 6% of children with Crohn's disease can present with anterior uveitis. In sarcoidosis also, anterior uveitis is most common, and they can also come with the complications of band-shaped keratopathy, cataracts, and glaucoma. Inflammation of the posterior segment in the form of retinal vasculitis or multifocal choroiditis can also be seen in sarcoid. Now let us look at an unusual case that we had to deal with. A 10-month-old female baby with abdominal distension, recurrent loose stools, progressive skin lesions associated with swelling of hands and feet, failure to gain weight. General examination showed pallor, depigmented hair, hypopigmented scaly skin lesions, and ophthalmic examination showed a typical JIA kind of uveitis, bilateral anterior uveitis, festooned pupil, multiple posterior synechiae, and early band-shaped keratopathy. So this is a 10-month-old child who presented to us. On systemic investigation, however, she had a lot of systemic inflammation. Skin biopsy showed ill-formed granulomas with Langerhans giant cells. Liver biopsy showed granulomatous inflammation. Histopathology, these are the histopathology specimens. Stool was positive for occult blood. There was granulomatous duodenitis, colitis, and they sent for an NOD2 gene mutation, which came negative, and a diagnosis of infantile sarcoidosis was made. Improved well with systemic immunosuppression and topical steroids, underwent cataract surgery also in one eye, and is on follow-up. So it's important for us to think that all the anterior uveitis that presents asymptomatically need not be JIA, and a full systemic evaluation needs to be done. Early onset sarcoid is what this child had. A close differential diagnosis is the Blau syndrome, which is the familial juvenile systemic granulomatosis. Of course, that will come as a genetic test positive. Behçet's uveitis can occur. Pediatric Behçet's is uveitis at the age of 16 years or younger, which fulfills the diagnostic criteria. Male predominance, there may be a family history, bilateral involvement, presence with recurrent panuveitis with vasculitis. Now, treatment, local treatment of non-infectious uveitis, corticosteroids is the main treatment. Topical corticosteroids are initially used. And one important tool in our armamentarium is the periocular or subtenon corticosteroid injections and the intravitreal implants. Now, treatment of complications is what we usually have to deal with as ophthalmologists. Cataract, of course, is now, earlier it used to be extremely controversial whether to implant the intraocular lens or not. Now, with good immunosuppression and control of uveitis, if you have a 3-month activity-free interval, you can go ahead and implant the intraocular lens. But you have to be cautious because severe exudative reaction is the norm, and stepping up of immunosuppression 2 weeks prior and continue for at least a month after is required, and slow taper of systemic and topical steroids. You may need to continue topicals for more than 6 months. For band-shaped keratopathy, we can do EDTA chelation or phototherapeutic keratectomy. For cystoid macular edema, you can do the posterior subtenon triamcinolone or an implantation of the intravitreal Ozurdex. Now, this is a case which unfolded like a Netflix serial. A 3-year-old boy diagnosed outside to have bilateral non-granulomatous uveitis, referred to us in 2015. Vision was 6/6 when he presented, but band-shaped keratopathy, festooned pupil, and early PSC with mild activity was there. He was already diagnosed to have JIA, and he was started on systemic methotrexate, topical steroids. He was doing well. 1 year after his presentation, his vision dropped due to very thick VSK in both eyes, for which he underwent bilateral phototherapeutic keratectomy. Following the surgery, his visual acuity improved. He was maintaining 636 with Snellen. Central cornea was clear. A year later, cataract progressed, which caused decrease in visual acuity. He underwent cataract surgery with IOL, first right eye, then left eye. Now he had a visual acuity of 618, 624. 1 year later, he developed an organized membrane behind the IOL in one eye, and he underwent a pars plana membranectomy. However, post-membranectomy, his visual acuity dropped to perception of light. B-scan was done, which showed a thick detached posterior hyaloid with a lot of vitritis, but there was no retinal detachment, disc edema, or even choroidal thickening. His immunosuppression was stepped up and ectampsia was started. He was also given intravitreal Ozurdex, and 1 month later, his vision improved to 6/60 and the vitreous inflammation came down significantly. 3 months he was lost to follow-up, came back practically blind after 3 months. Now he had right eye counting fingers close to face and left eye 2/60. This time it was a thick membrane in front of the right eye IOL and a recurrence of the yellow glow with vitritis in the left eye. Now he underwent right eye surgical anterior membranectomy and left eye second implantation of intravitreal Ozurdex, and post-operatively vision recovered in both eyes, and presently the child is 624, 618. So this case is just to highlight that patience, perseverance, appropriate diagnosis of the complications and timely intervention is the key to a good outcome in many of our pediatric uveitis patients. This is one last case, bilateral pan-uveitis with severe vitreous haze, complicated cataract, BSK, presented to us with hand movements in one eye and 6/60 in the left eye, but the child also had hypotony with ciliary shutdown. And this time it will not be enough to do just a cataract surgery alone. So the child, this was the eye, and the child underwent cataract surgery with vitrectomy and oil and is now maintaining at 612. So that brings me to the role of vitrectomy in pediatric uveitis. Very rarely we need it for diagnosis, but mostly we need it for therapeutic purpose with grossly reduced visual acuity due to vitritis or severe hypotony due to cyclitic membrane, or if you have an associated rhegmatogenous retinal detachment. Now with the advent of small gauge, there is very less morbidity, and the role of vitrectomy is also very important in management of our pediatric uveitis patients. In conclusion, it's a challenging subspecialty and requires close cooperation between the pediatric rheumatologist and the ophthalmologist to ensure accurate diagnosis and optimum treatment outcomes. Thank you all for the patient listening.
Thank you, Dr. Natasha, for giving a very good overview and giving a case example, real life example of pediatric uveitis. We need to be very mindful about pediatric uveitis. The reason is that they have got whole life in front of them. If they become visual loss, significant visual loss, they could be handicapped. And the two common uveitic entity is seen in the anterior segment is that juvenile idiopathic arthritis associated uveitis, as you have told. Another one which you should not miss is an intermediate uveitis or pars planitis. And if you have suspicion, if it is a very small child, you can do an examination under anesthesia. Children immunosuppressive agents in GIA is very good, particularly methotrexate. They tolerate very well. And nowadays one can give a subcutaneous injection of biologics called adalimumab, which is also very good in juvenile idiopathic arthritis associated uveitis. Very nice presentation. Thank you very much. Now we'll go for the last presentations or my presentation. I
think like you will try from your side.
Yeah. So I have to just see that.
Last is always reserved for the best. So
like we said in the last presentation, last is the best.
So share screen. Then I have to have the pulse of uveitis. Opening. Let's see. So here, no?
Yeah, you have started screen.
Can you see the slide?
Yeah, yes, sir.
Okay, I'll make a big screen.
Okay.
Successful. So at the outset, I like to thank Cochin Ophthalmic Club and particularly Dr. Gopal Pillai. And he has done a real good coordination among us and chooses the whole gamut of uveitis is covered. I am glad that Rima called a part of the pan uveitis also. I am not going to talk many details of the uveitis. I have just 33 years of experience on uveitis. I just wanted to give some pulse of uveitis. So let us start with a case. It's a very challenging case. 30-year-old female, immunocompetent. What could be the diagnosis? So now it's impossible to listen to you, but it's a challenge to the diagnosis. And you can see the lesions is bang on the macula. you may find difficulty in the diagnosis, but if you look at the patient as a whole, it is not that difficult. And you can see the vesicular lesions on the forehead. And you can get the clue that this retinitis, as mentioned by Dr. Rima, that characteristic feature of retinitis is whitish lesion, retinal hemorrhages, the veins are not going over the lesions. And this is a retinitis, and you can get the clue that the patient had vesicles on the forehead, which suggests that this patient have varicella zoster retinitis. And in fact, this patient was responded very well with after intravenous acyclovir therapy for 7 days. The lesson, the pulse from here, in uveitis, you don't put the patient in dark room and see the slit lamp and fundus with indirect ophthalmoscopy. Look at the patient as a whole, which Dr. Partho was also highlighting. It's in addition to the slit lamp and indirect, we need to look at the patient as a whole. This is another routine case referred from Mumbai. This patient came to me, 43-year-old male, dimness of vision and floaters. He was diagnosed as CMB retinitis in both eyes. And he was given, in fact, intravenous ganciclovir. He was HIV positive. So I shake hands for every patient. So I used to do it. And after this, I might have to be careful. When I shake hands with the patient, I found something wrong in his hand. And what is this lesion? What I found, there is a syphilitic lesions in the hand. And when I look at the fundus, there is a typical features of syphilitic retinitis with subretinal deposits with the secondary retinal detachment. So this, which helped us to make that the examination of the patient as a whole helps us to clinch the diagnosis. The patient was indeed syphilitic retinitis, RPR and TPHA. You can do VDRL also, came positive, treated with the intramuscular penicillin, and you can see that what a great X resolutions has occurred. So it was an accidental finding, but be mindful and look at the patient as a whole. Examine the patient as a whole. Is an uveitis is often a manifestation of systemic disease. This is a 47-year-old man, pain, redness, and swelling for 2 months. It's not a uveitis actually, it's a diagnosed as a tumor with intraocular extension. Advised radiation and brachytherapy for thinking of this is a tumor and came to our hospital for the same. And when you look at the eye, you see that really a big, large mass of the sclera. And there was a ultrasonography showed no intraocular extension, but UVM showed as a homogeneous mass arising from the episclera and sclera. So clinically, it is a nodular scleral inflammation. Patient was asymptomatic and major systemic illness. We did the autoimmune workup as we do in all cases of scleritis, RA factor, antinuclear antibody, antineutrophilic cytoplasmic antibody, C-ANCA, the C-ANCA, P-ANCA. What left? We were thinking that we were scratching out the vein. What left? What could be the reason for this scleral nodule, scleritis, nodular scleritis? So then we thought that we need to think out of the box, and we did VDRL and TPHA. VDRL, TP, and RPR was found to be positive. TPHA was also positive. And this turned out to be a nodular syphilitic scleritis. And you can see that what a dramatic response with intramuscular benzathinin penicillin. So what is the lesson? This is sometimes you need to think out of the box. You see all the textbook things that is rheumatoid arthritis and weakness, and these are the common, or tuberculosis, common cause of scleritis. But one need to keep the last option, that's the syphilis could be the reason for scleritis. Syphilis, as you know, is a great mimicker. It can present any type of uveitis, anterior, intermediate, posterior, or pan-uveitis, retinal vasculitis. And today is showing you a scleritis caused by the syphilis infection. This was published in that one. This is a nodular syphilitic scleritis. What I want to highlight is that one need to think out of the box and to come to and clinch the diagnosis. This is a 30-year-old Indian male he referred from the USA, and they thought that this patient had serpiginous choroiditis. He has got metamorphosia in both eyes for 10 days. This is the right eye, and this is the left eye, which showed that there is a pinkish yellow lesion, and it indeed had geographic border. So that made the clinicians in USA think that it is a serpiginous choroiditis. But I thought it's a little different. I thought that let's do an ultrasound. And when I did an ultrasound, we found that there is a calcific lesions, bony lesions in the posterior coat of the eye. And CT scan clinched the diagnosis. And you can see that the calcific lesions is a bony lesions in the one. So what it is not a serpiginous choroiditis. What it was, a choroidal osteoma. So sometimes you need to really rule out the other conditions, that always keep an open mind. So somebody comes with a diagnosis, you don't keep the other options closed. So you should keep an open mind and make a change in diagnosis. If you should be brave enough to go for a necessary investigation, ancillary investigation, which is quite important. This is a 57-year-old lady, painless gradual dimness of vision. This was, I was talking to Dr. Rima's case, and this patient came to me about 15-20 years back. So I have seen such cases when I was getting trained in Doheny Institute, USA. So I thought that this case mimics like that. So it's not a serpiginous choroiditis. The patient was treated with antitubercular medicine. And I found that the skin, the lesion, leopard skin-like lesion, dot-like lesions, whitish, in the choroid, and suspected intraocular lymphoma. And then I suggested that let's go for a tissue diagnosis. And with the help of Dr. Mahesh Vishwamugam, who is now in Bangalore, who did the fine needle aspiration biopsy. And in the fine needle aspiration biopsy, we see the characteristic lesion. When you see necrotic lesion from a biopsy material, intraocular biopsy, you should think of a tumor which is called lymphoma, primary vitreoretinal lymphoma. This is supposed to be a primary vitreoretinal lymphoma. If you look at the fundus pictures, you might think that this is a choroiditis, but there is no really pigmentations and all. And this 6 months was put on antitubercular treatment. We made a change in the diagnosis. So I was correct. 6 months after, patient developed CNS lymphoma. So be mindful in identifying a lesion. This is a case, is a 35-year-old man, dimness of vision 1 month, diagnosed as choroiditis, treated with a high dose of oral prednisolone, and things worsen. Is it really choroiditis? So any type of choroiditis, we should do that fundus fluorescence angiogram. We did fundus fluorescence angiogram, and what it turned out to be a completely different and ultrasound multiple leak CSR, that's a point leaks and is pulling of the dye in the late phase. So it was found out to a multiple leak CSR, which was treated as a choroiditis with choroiditis with the systemic steroid, which is really opposite type of the treatment in multiple leak CSR, which get worsened with the steroid. Lesson learned is always do a FFE in all cases of active choroiditis. So you can miss or you can make clinch a diagnosis in many of the cases. Last but not the least, this is a 15-year-old girl, sudden blurring of vision in the right eye. Vision was counting finger at 50 centimeters, and the slit lamp showed diffuse KP studded over the cornea. I thought that this is a vitreous is hazy, and this is TB or sarcoid. And this was the KPs all throughout the posterior surface of the cornea. Can you imagine what I found? This patient, I did an anterior chamber tap to rule out tuberculosis because that is one of the common cause of granulomatous pan-uveitis or granulomatous anterior uveitis. And indeed, ACTAP for PCR for MTB was positive, and it was positive for MPB64 gene for TB. I put the patient on anti-TB treatment with the topical and systemic steroid added to it. But when the inflammation healed, can you imagine what I found? It was typical toxoplasmosis, toxoplasmic retinochoroiditis, when the vitreous is cleared. So toxoplasmic retinochoroiditis can present as anterior uveitis, particularly granulomatous anterior uveitis. So that's a very rare presentation. But what the lesson is that any patient with anterior uveitis, at the earliest opportunity, we should see the fundus to rule out acute retinal necrosis, rule out a toxoplasma lesion or intermediate uveitis. So this is my learning point, and I like to share with you. And it was a toxoplasmic retinochoroiditis. And what in conclusion I say, uveitis can befool you, and it requires a meticulous history taking, meticulous examination, as well as ancillary, depend on the ancillary investigations. You can learn by that process. And I didn't do the ELISA for the toxoplasma in this case. That was a mistake. So your clinical acumen, clinical suspicion will be top on the list. Don't depend on that laboratory investigations like MANTU, quantiferon, etc. What it clinically looks like, that you will be really convinced with that one, and laboratory investigations is supported by me. So I was misguided with the PCR. That was a mistake I made. And in fact is that uveitis is a really challenge. Every day it will bring some surprises, and you need to learn of it. And I am learning after 33 years. Also, I am learning. Thank you very much. Thank you, Dr. Gopal, for giving me the opportunity.
Sir, thank you for giving the opportunity to hear you, sir. Thank you very much.
Thank you. So I will conclude. I will ask Dr. Gopal Pillai to conclude. I like to thank all the speakers.
Dr. Partho
and Dr.
there. Dr. Partho.
Partho.
Yes.
Yes, sir.
I've got just one doubt. You mentioned about the 3-piece IOLs in the sulcus.
Yeah.
The 3-piece foldable IOLs, I think, can be safely placed in the sulcus. The single-piece ones, which really cause.
Yeah, I'm sorry. I realized that it will be single-piece IOL. Correct.
Yeah, it is single-piece IOLs which really cause a.
Correct. Yeah, I'm
problem.
extremely sorry. It will be single-piece IOL.
And sir, one doubt to Dr. Bishwa, sir.
Yes, please.
Sir, this osteoma, can it, I mean, when does it cause metamorphopsia? It must have been there for a long time, but
yes.
What has triggered that symptoms?
Choroidal neovascularization. That's very common to develop osteoma. That's why the patient develop metamorphopsia and the distortion of the vision. The choroidal osteoma is not a 1 or 2 days patient. It must be a long time, and the patient become aware of it when he develops metamorphopsia. So this is what I want to impress is not a diagnosis of choroidal osteoma. I think is that you should have a mind open, broad diagnosis. So any patient coming with the choroiditis or vasculitis or anterior uveitis, you should keep all the possibilities and make your clinical diagnosis, but keep the options open and depend on the ancillary investigations after that one. Laboratory investigation is supportive only. This is the message which I want to give it.
Thank you so much, sir. It's always a pleasure to hear your talks
and
your rare cases. Thank you so much. Gopal,
thank you very much, sir.
Yeah.
So first of all, thanking Dr. Jyotirmay Bishwa, sir, very much for, it's not just an overview of uveitis, but an overview of philosophy to uveitis, which you have been speaking about. Keep your mind open, mindfulness. All these are philosophical things that you have to want us to treat uveitis. It is a wonderful opening by Dr. Anuradha. Just gave the basics, and then Dr. Partha. It was very nice to stick to 10 pearls, which the postgraduates and the young ophthalmologists will actually take home, and a very complete posterior uveitis. Even though you've cut down a lot, probably that's a 1 hour talk which you reduced to about 10 minutes. Thank you, Rima, for a wonderful talk. And it's always a treat listening to Dr. Natasha. And finally, the icing on the cake was the pearls in uveitis by Jyotirmay Bishwa sir. Thank you very much. Natasha or Rima, can you take a screen photo so that we can take a photo together? Is it possible for one of you?
Prashop, can you also join?
Prashop,
John?
or
John, yes.
Yeah.
I think they are in the trial room running a trial for the cataract session.
Cataract session, yeah.
So that's why I asked one of these people, selfie specialist.
Thank you, Gopal. Excellent opportunity, and give uveitis a chance.
Yeah.
Uveitis, a specialty, doesn't get chance that much. So
no, sir.
Okay.
No, definitely we will take it forward, sir.
Sure. Thank you.
Thank you very much.
Okay. Thank you.
So we can leave now.
Yeah.